We will start soon. Yes, Dr. Carlos, how are you? Do you hear me?
Hello, good morning.
Good morning. Do you hear me? Is it okay? Do you hear me now?
Yeah, I hear you now.
Yes, yes. How are you?
I'm doing well.
Okay, I think we are going to start to save your time.
All right.
First of all, thank you very much for your nice presentation yesterday. But maybe some people they didn't hear the introduction yesterday. Everybody, this is Dr. Carlos. He's a general and digestive surgery master and he's from the Cardinal Herrera University from Spain. And he is an instructor C of European Trauma Course, European Resuscitation Council. He is currently appointed as in a general acute care trauma and GI surgery at Royo Villanova General Hospital, Aragon Health System, Salud, Zaragoza, Spain. Thank you very much, Dr. Carlos. Please start your presentation.
Thank you so much. Or like I said yesterday, uh, thank you so much for this kind invitation, for the opportunity to share this meeting. I hope that yesterday the rest of the lectures went out well. And today we're going to be speaking on. Yesterday we talked about specific measures of PPE and how that influenced surgical performance. Well, today we're going to be talking about more of that international cooperation group, this time regarding emergency surgery during the COVID-19 pandemic. So I have no disclosures to declare. And like I mentioned yesterday, here we have our cooperation group. This is a very nice group. As you can see, there are people from all over the world, from Poland. We have friends also from the Emirates. We have friends from Brazil, Portugal. So it's a good group of cooperation that really came up during the meeting and during the several conferences that we had regarding all these issues. So our work basically on this second presentation would like to focus more on the differences that we suffered during emergency care, surgical care during the pandemic, because the workflow, like we mentioned yesterday, changed drastically. And in the first phases of the pandemic, we had several recommendations from several international associations. So we wanted to assess what was the measure of acceptance and how were these recommendations being followed individually in each of the different countries. We focused our work basically on 5 aspects. We wanted to know about team organization. We wanted to know some, of course, PPE related aspects, because we focus a lot on PPE, the preparations in the operating room, anesthesiologic considerations, and also surgical management, all related, of course, to the acute phase of the first and second wave of the pandemic. So our response, as you can see here, was basically similar to our other study. It was mostly from Europe, 63%. We had some responses from the Middle East. That's interesting that you guys also participated. I have a couple of friends there, and Dr. Mohamed Atfar. I was also a member of the group and a friend and a kind collaborator. We had some responses also from America. So we had a picture, again, more basically of Europe, but we also had some response from other parts of the world. So the interesting things here were basically that we had 134 questionnaires launched out, 26 countries. Most of us were surgeons. Most of the people participating were surgeons. Most of them were involved with management of COVID patients. It was interesting to see how 91% of the respondents accessed social media for immediate recommendations. The things were going out really fast. So social media turned out to be really useful to spread the message and the general recommendations of the different societies. We personally, in the Spanish Surgical Association, developed several papers and used social media among the newsletter and social media to spread the message. And also video conference, very, very common, and they still are today. So as we can see here, regarding the surgical team organization, 81% of the respondents got involved in what we called the task force. All, of course, from a surgeon's perspective, but we were really involved in organizing the team and getting things together. 71% were developing protocols, because the protocols, even though we got international recommendations from different societies, the protocols had to be established in each one of the hospitals, because each area, each region, each country has its limitations, has differences. So it was very important that everybody worked on their proper protocols. 69% were implementing safety precautions among their healthcare personnel and patients. And about half were performing task management, basically organizing what was going on, who was doing what. Social media, again, as we can see here, was used by almost everybody. 9 out of 10, 91% were using social media. Most of us used WhatsApp as a quick method of communication, but some YouTube and some Twitter. I have a video on YouTube of the first pandemic, and it's really nice. We made for the students and for the rest of co-workers, and it's available. You can look at it if you want. The other thing that really struck us was the training of PPE. It was surprising to see that half of the respondents had not received any training before for airborne infectious risk while performing emergency surgery. So we found there was a clear knowledge gap that had to be addressed, and proper training and simulation has to be mandatory for all emergency physicians, especially for surgeons in my hospital. And even though more than half had not received it prior to it, 37% did it during the study period, but most of them thought it was deficient. So we think we have to emphasize in the training of proper donning and doffing of PPE. Regarding personal protective equipment, almost everybody was using masks, whatever mask they could find, basically on that initial surge. Now we use mandatory masks throughout, not only in the hospital, in the ward, in the OR, but also in the streets. But in that phase, in those first and second waves, 28% of the doctors that participated, or the surgeons that participated in the study, wore N95 or FFP2 or 3 masks, even in the ward without patients inside with COVID. So it was interesting. 66% had a specific area for donning and doffing. 33% employed checklists and buddy checks, about 60%. Buddy checks we use that a lot. We have a specific area for doffing and donning. And buddy checks, apart from the checklist, you have like a coaching that, because sometimes you're stressed, you're nervous, or you have several teams that can collide, like the cardiovascular team or the GI team or endoscopists. So you have to, have somebody there that can tell them, hey, put the mask on, how you should do it, that checks them, helps them, so everybody feels comfortable. It's also important that you do a mask fitting test. So you have to put your hands and and test. You have to test. I have several types of masks, so you have to really test them and see if you're getting a good seal. That's very important, especially with the beard, because I didn't have beard in the start, but now I've grown a beard a couple of weeks or maybe a month now. So I have to shave that because it's better to have your face clean without hair. It gives you better seal. And here we see the PPE that was used. Basically, less than half used everything: face masks, double gloving, goggles, long sleeves, disposable gowns, and shoe covers. But we can see that not everybody wore everything. So it all depends on your protocol. So this is what I was talking about. This is basically in each of our COVID OR. We have here the checklist, and we have a coaching that's helping the nurse putting on the material, the PPE, and this is an anesthetist. And she's using the mirror. That's very frequent now to have mirrors in the PPE donning and doffing area so you can check yourself when you're putting on the equipment. It's also very important to ramp up material. It's amazing how fast the material you need to pile up and be prepared, because you're going to need a lot of material, especially with the surges, the different waves. The first wave really caught us out of guard. On the second one, what we did is that we stocked up a lot of material, and we made up, like in offices and places that were not regular for depositories. We had like emergency had a backup of material always available. But even though we did have PPE shortage, I mean, who hasn't? And in our study, it was interesting that 73% reported shortage of any of these items: the face masks, the goggles, the gloves. 73%, at least one of the materials was on shortage. But what's most interesting is that 77% had shortage of N95 masks. So that's very, very important. That's very serious because it's an airborne disease. So what we did, and what a lot of people have done, is that we had to reuse the masks. So in our study, 55% of the people had to reuse masks. So we used to have, this is clean, this is dirty. So when you went out of the OR, you had a specific area. So you put your when we needed to reuse, we put the dirty ones here. We named them with our name, and we applied ultraviolet, and we were able to use them at least 2 or 3 times. And in the difficult times of the pandemic, we even had to have one mask for one surgeon during the whole day. So that's not, of course, the ideal scenario, but I mean, we did with the best we could. Regarding the improvise or improvisation of material, because you have shortage, we did find that about half of the people that we were surveyed had to improvise some part of their PPE. So the most frequent was reusing of masks. We also had a lot of people improvising face shields, like the ones you see here, and this one is a 3D printed, and this is a non-3D printed, but it's an improvised face shield. They were useful, but they were not good for surgical procedures. They were good for ward activity or maybe doing a triage. But in the surgical in the surgical intensive care unit or in the surgical theater, they were not good because they were not really transparent. And even gowns, we have some nurses that had to come up with this improvised gowns with bags. So we had our difficult times. Regarding operating room preparations, around 77% had COA. That's a COVID operating area specific for COVID. We had specific OR facilities prepared and modified for COVID. And we also had a trauma area. So in our study, about close to 70% had a trauma room specifically for COVID. And what we did basically was clear out all the unnecessary equipment from the OR, leave it as clean as possible, protect all the monitors on all the electric equipment, with plastics. So this is basically what our emergency or COVID area would look like, and still is today. We have 3 theaters like this prepared, and we see that the red disposable for biohazard, the least amount of material, and just the basic laparoscopic tower there, your PC, everything covered in plastic, and that's about it. You know, that you didn't get much more material than that. Everything, like I said, everything had to be covered to communicate inside and outside the OR. We used to use walkie-talkies or even sign language. Sometimes we had a code, a sign language code for communication, because these doors were closed and they didn't open until you finished the procedure. And that's still the protocol we're applying today. Regarding the smoke, there was a lot of considerations at the start of the pandemic because of the capacity of infectious transmission through the surgical smoke. So there are some equipment that we have now that are these OR vac. There are machines that they have this filter that you can change, and they're really good to maintain a healthy air condition inside the OR in open or laparoscopic surgery. But only 26% had smoke of the survey, only 26% had smoke evacuation systems, and 43% had to improvise. When we started, we had to improvise. We published this paper. It's also open access. You can download it if you want, preparing for an unprecedented scenario. And with this, what we did is with a 12-millimeter trocar, a smoke filter, and a canister with sodium hypochlorite, we prepared this system to be able to evacuate the pneumoperitoneum. So you have this on colorectal disease. And this is just a short video. You can look at it. We also published this in colorectal disease, and it's with very basic material. You can prepare a system to be able to filter the smoke. So as you can see here, you don't need fancy stuff. Just a smoke filter, silk spray. You have to have a canister and some universal connections. And with this, I'm gonna just go and ramp it up a little bit so we can gain some time. We were able to design this system that we use, that silk spray, that's lubrication. So what we did is we created a closed suction system to be able to evacuate the pneumoperitoneum. So you got this available. It's a video. There are several videos on these publications, and it may be nice for some people that are watching that to download it and to take a look at it. It's very simple, and it gives you step by step all the things you have to do just to prepare the evacuation system. It's a closed system, and then when you finish, you just close the valve, you take out the canister bag, and you can just safely dispose of that material to the biohazard red bag without any risk of contamination. See, as you can see, the system's closed, and you can just remove it and throw that away. So regarding anesthesiologic equipment considerations, it's also another important issue, because anesthesia also, since they have to intubate, they're at high risk for virus transmission. So when we asked them, what we did, as most people are doing, we created a direct circuit to the OR. The patient didn't go through the pre or post-operative anesthesia care unit. It just went directly to the OR. He was didn't go out to the post-op unit. He just recovered in the surgery department, and from there it went directly to the ICU or to the COVID area. So most of the people had this taken in place, 64%. Regarding the equipment, it's very interesting that you should have a resource box available for difficult airways. You should also have cheat sheets or maybe what we call checklists to have all the material prepared for the anesthetist, because that's a sensitive moment when you're getting that airway controlled. We didn't go inside the OR until the airway, the patient was intubated to minimize the risk of virus transmission. That was more at the start. Now we're a little bit more coordinated, a little bit more seasoned, and well, we have like, it's like a ballet, it's all coordinated, and things go a little bit more smoothly. But even though you should not relax, you should not be overconfident, because overconfidence can also be a very dangerous scenario. In our study, only 25% said to have a specific trolley for airway. So what we recommend is to have all the material prepared. Our experience to have an independent trolley with cheat sheets, with checklists, and of course with a video laryngoscope, so you don't have to intubate with a normal laryngoscope. That's really mandatory today. The rest, regarding the technique for rapid induction or rapid sequence intubation and induction, not everybody was applying it, and we didn't get information with that because we didn't have too many anesthetists responding to the survey. Most of us were surgeons. Regarding the intraoperative management, almost 2/3 used COVID-19 specific checklists before surgery. We did it. We did a specific checklist for COVID, and we're still doing it today, making sure that everybody had their material prepared. We did a group meeting before the patient comes up to the OR. The surgeon is the one that has to coordinate the whole team. It's a team leader. He is responsible not only for the patient, but also for coordinating the material that's going to be necessary for the surgical procedure, the personnel that's going to be necessary, and all the equipment. So it's very important that you plan ahead and you don't get any issues in the middle of the surgery. So we used to have all the material prepared in kits. So you could have a basic laparotomy kit, a vascular kit, thoracotomy kit, trauma kit. And so that way you just don't have to open different material. You just open one kit and with everything available there. Regarding the performance of the surgical procedure, initially there was a lot of concerns with laparoscopic procedures because of the risk of air contamination and the biohazard of the fumes. I think this was overrated at the beginning of the pandemic. And there were a lot of issues with laparoscopic management, but we did perform a lot of procedures with that smoke evacuation system improvised. Then we got we bought a couple of normal OR vacs, and now we have them. But even though there were risks, I think they were overrated, and we did perform a lot of laparoscopic, and we do. Most of our surgical procedures are laparoscopic. So I would say that if you do the things well, you work with low pressures, you try to keep it below 12, you're going to be fine. Don't try to not generate too much fumes, and be careful, because sometimes you can get that chimney effect with the trocars, but we did perform a lot of procedures laparoscopically. Even though when we did ask people regarding what they were doing, 44% had performed COVID-related surgery directly. Now I think it must be much high. In my department, everybody's performed COVID patients in all the units. We don't have specific surgical units for COVID. We have specific areas, but all the surgeons perform COVID-related cases. And the emergency attendants like me and trauma and acute care, we're all seasoned now with these type of patients. But when we did ask, and we did find that most of the people still preferred laparoscopic approach, and that's something that didn't surprise us. When we asked about the screening methods, that's another thing that was interesting. Back then, we didn't have PCR like we do now. I mean, remember that we started this in the first and the second wave, so that the PCR tests were a little bit slow. So at the beginning, we were using even CT, chest CT. So I was talking with my colleagues yesterday. I say it's incredible. I mean, it's been a year now. And you remember how we were about a year ago? We were asking for CTs to see if we had pneumonia, COVID-related pneumonia or findings. Now, systematically, all the patients get tested in the emergency department before going into the hospital. All the elective cases get tested 48 to 72 hours. They're self-quarantined and self-isolated before surgery. PCR tests are standard now, but back then 50% were doing PCR, and some were still using CAT scans and even some people ultrasound to find the diagnosis. And when asked if the number of emergency cases were the same, that's another thing that I think was also universal. On the first wave of the pandemic, the number of cases, because we have very severe lockdowns, the first wave we had like a quiet emergency department, surgically speaking. We didn't have that many patients, but we did find that a lot of the patients that were coming in, they were coming in with worse conditions, peritonitis because they had appendicitis that was perforated, or very complicated cholecystitis or diverticulitis. So we had the common disease that came in. They were a little more complicated. On the second and the third wave, we found something interesting, that we started having normal cases like every day. Right now we have more cases because we have a lot of surgical patients that were not treated on time. So we're really trying to get up on the numbers, because we have a lot of procedures to do, but we still, in the emergency department, we have a lot of surgery now, and it's normal. But in some cases, there's even been a spike in trauma cases related to psychological and lockdown issues. So this is important. In conclusion of our study, we'd say surgical team members have responded with leadership to the COVID-19 pandemic with crisis management principles. And that's very important because we had no prior experience with this. So as leaders, in my department, we acted as leaders, the surgeons, independently in their department, but also inside the healthcare system, along with the ICU and some emergency physicians, had to really apply crisis management principles. Social media and video conferences are now very common, even more than they were before. They're a useful tool, but we must be careful because social media also can generate a lot of false information. So I think when we use it wisely, we must use it from official resources, and with video conferences, we should try to be careful also with some of the information that we share, because we have to be very careful with the privacy of the patients. The level of adoption of the current recommendations of the different surgical societies worldwide was high, especially for organizational aspects and surgical management, but not so for PPE training, PPE availability, and anesthetic considerations. So I think this is another big finding in our study that I think we need to address: better PPE providement. Yesterday I said that we need to have better PPE design to make it more comfortable, but also we need more PPE and more training. We have to do simulation and we have to do training, because this is not going to be the last pandemic for sure, and this is going to be here a long while, so we must be prepared. With this, mutual cooperation, mutual support, a lot of patients have fallen, a lot of patients have left, a lot of friends, colleagues are not here today. So we owe them to keep working and to stay strong and keep on fighting. So like yesterday, those that didn't see my talk yesterday, I invite you all to participate in this survey. It's an international assessment group of online surgical and trauma education. I apologize. I tend to get emotional at the end because we had a lot of stressful situations, a lot of colleagues, a lot of patients that have been affected, but we stay strong, we keep fighting, and we'll get over this. So please link in and help us out with your information, your input regarding our survey study. And with this, I thank you so much for this kind invitation. It's been a privilege to be a part of your symposium, and I'm sure the rest of the speakers and lecturers are going to be of excellent quality. So I congratulate you for this effort, and I'm open to any questions or suggestions or comments.
Well, thank you very much, Dr. Carlos. Actually, as you can see, it's a global issue. Many of us, either they lost friends or colleagues or neighbors. It is not that easy to pass this, at least in the coming few months, unless everybody get the vaccine and we go through. But as you know, there are some reports about the fecal transmission of the coronavirus. Do you think laparoscopic procedure, especially the bowel anastomosis, carry some risk in making infection or transmitting the infection to the operating team? Or you didn't think so?
I didn't get your question, sorry.
Yes, as you know, there are many reports about the transmission of the coronavirus through GIT and through the feces. Do you think doing laparoscopic procedure for the bowel with the anastomosis for infected patients, do you think it may carry a risk of transmission of the disease to the operating team?
No, I think if you do the correct procedure and you don't take any additional risk, you have your PPE and you have your evacuation system, there should be no worries. We've done a lot of procedures on COVID patients with anastomosis, splenectomies, diverticulitis, open surgery, laparoscopic surgery. We had no issues. Nobody was infected. But of course, controlling the fumes, using proper PPE, and using adequate pneumoperitoneum extractions. So you minimize the use of energy. If you have to open or convert the surgery, you have to evacuate all the pneumoperitoneum prior to that, and then you open the abdominal cavity. If you follow those steps, I think that the risk is minimal. You have more risk, I think, seeing a patient in the emergency department. That's my opinion. But you have to be properly equipped.
Do you have any levels for the PPE? Let's say mild or low level of PPE, moderate level of PPE, or high level of PPE for the most prone patients or the most vulnerable patients to be a source of infection? Or it's a standard for everybody?
No, we have a standard for the OR. We have a standard. If the patient's negative, we go in with a basic PPE, just a mask, the face shield, and a mask. If the patient is COVID positive or suspected COVID, we apply specific protocols. If it's a COVID confirmed or if it's a suspected, if you have suspected case, you have to treat him like it was COVID, because sometimes a PCR can come out negative, but the patient has clinical signs or radiological signs, and then we do a second PCR and it comes out positive. So if we have suspected case, we always do COVID protocol, always. If the patient is negative, has no clinical signs, it has been tested, and there's no COVID, we use basic PPE. We use our N95 mask, we use goggles, and we use double gloves. But we don't use any additional issues with that.
I see. Thank you very much, Dr. Carlos, for your valued time. It's really a pleasure, and it's my honor to be in touch with you. I'm sure we'll be in touch again, maybe in a few days, because we have to discuss, as we said yesterday, the potentials for a society, scientific society, who's taking care of physicians' medical safety during pandemic. So you will be, you are welcome to join us. Maybe I think tomorrow afternoon, evening, after we are the closing ceremony.
Perfect, perfect. I congratulate you for your efforts, for your kind coordination, for your patience, for all the emails shared. I wish you the best and the rest of the lectures. And I congratulate you once again. Good luck. I'm always available for cooperations, and thank you so much. And I must run, my friend. I have to go to the OR. Thank you.
Okay. Ciao, ciao.
Ciao. Have a great day. Great meeting. Thank you.
Thank you. Dr. Andreas Mallegren.
Good morning.
Good morning. How are you?
Pretty good.
It is my pleasure to be in touch with you. This is Dr. Andreas Mallegren. He is a famous colorectal surgeon. He is the chief division of colorectal surgery at the Department of Surgery of University of Illinois at Chicago in USA. There is a lot of publication, a lot of contribution of Dr. Andreas. It is difficult for me to eliminate all of them. But you are welcome, Dr. Andreas. Please start your presentation. Thank you very much.
Thank you. Thank you very much for your kind invitation. And I'll speak a little bit about COVID and share some experiences we have over here in the United States and how we are working with COVID in healthcare here, and also highlight some of the experiences we have today. So we'll see, we should share the screen here. And let's see. Do we have it now?
I think it is uploading.
So let's see. Do you see this where I'm working on now?
Yes, it is showing, yes.
Yeah, okay. I should find it here then. You have it now?
Yeah, I think it's uploading.
Do you see it now?
You have to double click over the file.
What?
PowerPoint didn't start yet.
Now?
Yes, yes.
Very good. So you have it now?
Yes, yes, go ahead.
Very good. So my talk should be about mortality and morbidity due to surgery in COVID era here, and I'll talk a little bit about that. I have no disclosures. So as we all know, this was totally unexpected now. We started seeing the first cases here in the United States in February of last year. I remember I returned from Sweden. I'm from Sweden originally, and I was at the airport in late January, and I had never heard about COVID, but it was notable one thing. I was waiting for my bag, and I came with Scandinavian Airlines, but the other beside us was a plane from China, and everyone had a mouth mask. So I discussed with my wife when I came home. I don't know, you always see a few Chinese with mouth masks, but it was almost 100% that had mouth masks when they were waiting for their bags at the airport here in Chicago. And I talked with my wife and said, I just wonder what that was about. Well, we know today, we got COVID. We saw the first cases in February of last year. 1 month later, we stopped doing any elective surgeries because our intensive care unit was full. We did still acute surgeries and some cancer operations. It was not much of a discussion at the time because we had no ICU space and we had few beds in the hospital open for any elective surgery. That blew over here in the United States. So when the summer came, and probably because of climate reasons, the situation became much better. So we started opening for surgeries again in June of last year. And we're still open. I'm going to talk a little bit about that. I remember early on, we had a patient who came into the hospital that will reflect well what we were looking at. This was a man who was sick. He was in dialysis, he had diabetes and hypertension. He developed a perianal abscess, but he didn't come to our hospital because he was afraid of COVID. He had heard about COVID and he was afraid to come to the hospital because he could get COVID at the hospital. When he finally came a week later, he had a severe perianal infection. And we saw him in the emergency room. He had fever, but he was stable still, but it was very clear he needed to go to the operating room. At that time, we didn't have any rapid tests, but we did a chest X-ray that was normal. He had no breathing symptoms whatsoever, but we took a COVID test that came back positive. So when he came to us, he was actually already had COVID, but he had no symptoms from it. We brought him to the operating room, and we're fortunate to have 2 rooms with negative airflow. If we know that a patient has COVID, we always use one of those 2 rooms. We revised the area. He got a large perineal wound. We treated him in the normal way, antibiotics. He was stable postoperatively, stabilized. It was never really a problem. He had no breathing symptoms whatsoever. But the scary thing with this man was that a few days later, on postoperative day 4, he started having breathing problems. And that was the COVID that was coming. And we did a chest CT at the time and had a severe COVID picture. And the next day, he came into the ventilator. And the following day, he died. It was nothing much we could do. We didn't really have any good treatments at the time. We didn't know that steroids can make a difference. We didn't really know to give him anticoagulation therapy, but he was a typical COVID case that passed away. That's what scared us all in the surgery department, was that he was actually totally symptom-free from COVID when he came, and for several days. And we thought that he was going to make it when he got the symptoms. So it's pretty clear now that COVID can be dangerous for patients who undergo surgery. And I'll review the experience we have with this. There are a few publications nowadays. They're all from last year and this year. This is a study that studied surgical intervention in COVID-positive patients. It's a Polish study. They have reviewed 229 patients that were COVID-positive, and they found a 30-day mortality of 16%, which is much higher than normal. Another study from Netherlands, it's a multi-center study, and they studied patients undergoing operative procedures, and they collected all over Netherlands patients who developed COVID pre-operatively or post-operatively, was mostly emergencies. And then they took these patients and compared them with similar operations, similar patients 1 year earlier. And then they looked at the outcomes. So they had 161 patients who had respiratory symptoms of COVID, and they compared these patients with 342 patients undergoing similar surgeries, but they had no COVID 1 year earlier. And they found that the mortality was significantly different. No, it was 16% in the COVID group versus 4% in the other group. Hip fractures are many times studied in many respects because it's something that is common. It affects many times older people, and it's a little bit standardized. It's the same kind of surgery everyone undergoes. There is a systematic review done, and they collected close to 1,000 patients, and 9% of these patients were COVID positive and were treated for hip fractures. And as you can see, there was a vast difference in this study, systematic review. So it's not only one study, it's 6 studies, as I say. So if you were COVID negative, it was a 2% mortality risk. These patients are many older patients, but with COVID, it was 36%. And the relative risk increase if you had COVID was more than 7. There's a very good recent paper that you can study in Annals of Surgery. It's a British study. It's also a multicentral observational study with more than 1,000 vascular procedures. Most of them were elective, and they have studied factors that influence the outcomes in the COVID era. And this is a good figure, and you will see the mortality rate and what will affect the mortality. So they looked at ethnicity. If you have COPD, you see that there is an increase of 1.7 in the odds ratio. If you have a current chest infection, it was a huge difference. If patients have respiratory symptoms of COVID, you see that the risk will increase tremendously. Whether they had COVID or not was not that important. I don't understand fully. It was more dangerous to have a suspected COVID than a confirmed COVID, as you can see. But you also see that sicker patients are affected more. If they were on antiplatelet therapy, you see you can decrease the risk significantly. And it's even more if you give an oral anticoagulant therapy. And urgent surgeries were more dangerous. So it's clear if you have an acute situation, you need to operate, and the patient has COVID, there is risk associated with this. And sometimes we don't have a choice. We have to operate. So, and I think if you do that, and I'll talk a little bit about PPE, etc. myself, but we need to do what we need to do. And I agree with Dr. Carlos that we as surgeons have become a little bit of leaders in the hospital because we cannot hide. Surgeons need to see the patients. We are there for our patients. And if you're a good surgeon, that's what you do. There is a study very interesting from Dr. Santoro, who I see here on the picture, his country from Milan. It's Moreno's group, who is a very active group. And they have taken on whether you can do surgeries or not safely. So they say that their surgical activity in 2020 was cut down significantly, as you see. But they are a busy cancer center. So they compared consecutive patients 5 weeks in March of 2019 with the same period in 2020. And the interesting thing is that they continued operating with cancer resection. So much of what they canceled was small stuff, hemorrhoids, other stuff that can wait till later. But the big surgeries they performed. And what they did report is that they did not have more complications in the COVID era patients if you do this safely. You can see that it was not statistically different, but if anything, it was less complications in the COVID era than during the year before. And they also reported that they could not find any COVID infections in patients or staff. So this mirrors a little bit what we think here, that it's clear that you need to do acute surgeries, but what should you do with cancer patients and other patients that would need the surgery and they cannot wait forever? So the question is, can elective surgery be performed safely in the COVID era? Well, this is our current policy. You don't get into our hospital if you don't test the temperature. Everyone has a mask on. If we have a COVID positive patients, we have more equipment naturally. We are lucky in my department. My chief took a stand very early on. He wanted us to be part of the treatment of COVID, but he himself started importing masks and other protective equipment, and you could almost not find him in his office because he had big boxes. And if you needed more protective equipment, you went to our boss and he would give it to you. And he had this privately helped. First he got masks from construction companies who donated the masks to us. And then we started importing masks ourselves from abroad because we didn't trust the system. Staff is also frequently tested. I just got an email this morning that I'm due to go and be tested again. And no patient gets into our hospital without a rapid COVID test. And that is if they need they can come to the clinic without the test, but if they have a procedure like a colonoscopy, my wife is going to have a colonoscopy on Friday, and she was yesterday and tested for COVID. It has to be within 72 hours. And it's the same for small surgeries, large surgeries, or if you come in through the emergency room, they will test COVID immediately before they admit you. The good thing here is that we also got access to vaccine now. I was myself vaccinated in December, and all staff on all levels and any function at the hospital have been offered vaccine since January. So we don't force people to take the vaccine, but everyone has been offered. And that's one of the good stories in the United States now. You know, right now we don't have it too bad with COVID. We don't know if we're just after Europe or if it will be a difference with the vaccines. Right now, close to 3 million people get vaccines in the United States per day. So that is something that is going very rapidly, and it's opened up for everybody within weeks now. What to do with elective surgeries and the patient has been COVID positives. Some patients show up without symptoms to the hospital, but they are COVID positives. This is the policy we have right now. It's adopted from the American Association of Anesthesiology. And you see we make difference whether you are asymptomatic or you have had severe COVID. We wait longer. This needs to be weighed naturally against what the patient needs surgery for. So sometimes if it's not that important, we will wait longer. Other patients, we will operate sooner. But this is kind of the guidelines we use, and it's working pretty okay. For instance, if you need a colonoscopy, and either for elective surgeries, this is what we use if you have been COVID positive. So this has been interesting. Last spring we closed almost altogether. We had nothing to do. But if you look what has happened with our surgical volumes, is that we did have, when you compare 6 months, July to December to 2020 with 2019, we actually in the colorectal group did see a few less patients in the clinic, but our surgical volumes are back to normal. If you count RVUs, we had 102%. We're actually slightly up in the RVUs, and there is no difference now in the spring either. And with the policies we have, we have not seen that in a patient of ours have acquired COVID because of surgeries we've done here at the hospital, and our staff is doing well as well. So in conclusion, COVID is dangerous. You need to take care. It's, as you know, more dangerous in old patients and sick patients. It is, I think, possible to develop safe protocols. We heard a lot about that with Dr. Carlos. We'll hear more about it. But I mean, it all circles around testing, protective equipment, and I think increasingly vaccines, at least to protect our staff, and more patients can now get the vaccines. I had a patient the other day who is healthy. He's had rectal cancer, and when I put the order in, he got the vaccine the next day. So it is very feasible here. And I think with the caution, you can do surgeries with safe protocols, and we don't expose our patients to significant increased risks, or not the staff either. Most of the staff is now vaccinated. We don't know where this will go. I mean, we hear about these variants that are coming, and more of the COVID infections in the United States are also with variants. And I'm sure that we will need more vaccines in the future. I had 2 vaccines myself in December and January, but I'm sure that we will need boosters with a better protection in the future. So this has come to stay, I think. But right now we're cautiously optimistic, but we don't know whether we will go the European way or we will be saved by the summer that is coming closer and closer here. And with the vaccines, we will see. Right now, the hospital is doing very well. I hope we don't need to re-experience what we had last spring, but only the future will tell. Thank you.
Thank you very much, Dr. Andreas. This is a valid presentation. I have 2 questions for you, please. Question number 1, actually it came from one of the attendants. He's asking, and I think you replied partially. He's a staff in the ICU, or I mean in the OR, and they booked a patient for lab chole. Although she was in the ICU for COVID-19, it was 6 months ago. So I think you replied in your lecture that 3 months is enough for a patient who was in the ICU to be operated afterwards. Is that right?
Yeah. So I think one of the differences is today that we don't really test patients. If you have had COVID, we found that many patients we feel are falsely positive. So we more use if you have any symptoms and then time frames. Because many times if you test the patients who have had COVID recently, they will be positive, but we don't feel that they are contagious. So we use more these guidelines.
The second question is, these are the guidelines for patients who either asymptomatic, symptomatic, or symptomatic patient with some chronic illness or in the ICU. But what about the surgeon himself or the medical staff himself? Let's assume that he is asymptomatic or he's symptomatic but no hospitalization. What is the proper time that he can go back to work safely?
I think the time has come down. If you were sick last spring, they wanted 2 negative tests, which could take significant time. Today, they don't test you, but you need to be asymptomatic at least for a week, I think. The minimum time is 10 days if you have COVID, even if it's rather mild. And we don't want anyone in the hospital who has symptoms now. So we're strict with that. And if you don't have any symptoms, you're tested every 2 weeks for COVID, all our staff.
But are there any publication about this? You know, the issue here that in some countries, because of the high volume, they pressure over the staff. They are asymptomatic, but they said it's okay, you are asymptomatic and everybody is getting corona. So why not to go back to work? So unless there are special, and this is the main reason of actually of this symposium, is to discuss how to protect the medical staff during the pandemic. So the issue here, the question here now, are there published guidelines that can elaborate this issue?
Well, our guidelines here is that if you're asymptomatic and you wait at least 1 or 2 weeks, then you can go back to work. And we've stopped testing those persons. So we don't test. If you have COVID and you're asymptomatic and you're home an extra week, you're welcome back without testing, because many of those tests will be false positive, we feel.
I see it. I think, any question from the audience, please? Thank you very much, Dr. Andreas. I think this is very valid lecture. And if you have time, maybe tomorrow evening, I think I'll send you an email to make a closing ceremony and suggestion for this symposium. Thank you very much.
Very good. My pleasure, my honor to participate.
Thank you very much.
Thank you.
Dr. Hafiz. Your voice, please.
Hello.
Yes, Dr. Hafiz, how are you?
I'm good, thank you.
We all welcome Dr. Hafiz Abdullah Karambabli. He is working in India, and he is currently, I think, in Jubilee Mission Medical College and Research Institute. Is that right?
With my post-graduation from this, right now I'm working at Government Medical College in the same state.
Thank you very much. Please start your presentation. Thank you very much.
Thank you, dear Dr. Al-Harbi and everyone for providing me with this opportunity to discuss things. And I think we all should be discussing what we should do in the COVID-19 era, because this era is going to last for maybe, God forbid, but a few more years. So we initially had, I'm primarily an otolaryngologist, and as we all know, the basic maximum viral load is in the bronchioalveolar secretions and the trachea. So, and many, since COVID primarily affect the respiratory system, we will get many patients for tracheostomy to ventilator, tracheostomy and back to ventilator, all those things. And at the onset of the pandemic, we all grouped together, we discussed, and with the help of my mentor, Dr. Suma Madam, we made this, a review article, which we follow in our institution in cases of tracheostomies. And we shall go into the presentation, but one thing is that even though we test the patients whether they are COVID positive or not, for all tracheostomies, even in a COVID negative patient, we follow this protocol, because we don't know, maybe after 2 days after the surgery, the patient may turn positive. So, and tracheostomy is a high-risk procedure in terms of COVID transmission. So we follow this protocol for negative patients also. Coming to a part of the presentation. Okay. I think you can see my slides now, right? Okay. So we went through many of the articles, and what was helpful was that there was previously MERS and previously SARS-CoV a few years back in parts of Hong Kong and in parts of Saudi, which has helped in giving their ideologies, giving their experiences in how they managed it. And what we come across along all these published articles is that around 15 to 20% with patients with COVID-19 may require endotracheal intubation and ventilator support during the course of their uh, disease. 20% patients of COVID-19 is a very large number. Lakhs and possibly crores are affected in that 20% means it is not a small number. And the indication for tracheostomy in a COVID-19 patient can be when we expect prolonged ventilation, more than maybe 10 days. Previously, we waited for 21 days or until the patient was on ventilator for somewhere around more than 2 weeks to think about tracheostomy. Now we have relaxed our guidelines a little bit, even if the physician or the medical person says that the patient is going to require ventilation for a long time, we will do a tracheostomy if he requests it. Then the other problem is when you don't get an airway access and the intubation is unsuccessful, then you will have to think about a tracheostomy. And there are two methods basically by which we do. You can do a percutaneous tracheostomy and a proper open tracheostomy. Percutaneous tracheostomy requires less training. It can be done from the bedside, and it is compared to the open tracheostomy, it is a bit more, what do you say, less invasive. But the problem is percutaneous tracheostomy primarily is a blind procedure. Second, to do the dilatation and to get an opening in the tracheostoma, we have to puncture the trachea multiple times. And during these multiple times puncture, we are entering the patient's airway and opening it to the environment, again entering and opening it to the environment, which is considered more riskier than doing an open tracheostomy where we do everything with proper, what do you say, proper precautions. So ideology is to do an open tracheostomy and to avoid percutaneous tracheostomy in COVID-19 patients or any patient showing any symptoms of acute respiratory distress syndromes. And when we went through many articles, it was found that ventilator-associated pneumonia and overall mortality has no improvement. Has no improvement if the patient has underwent an early tracheostomy or not. So that is not a factor here. That is to avoid ventilator pneumonia or to improve the mortality. There is no point in doing an early tracheostomy. The aerosolized viral particles can transmit 3 hours or more once into the environment, and there is no anticipated timing for viral clearance in critically ill patients, and they may have significant even up to 3 weeks. We even had excuse me, okay, thank you. We even had a healthy patient who was somewhere about 30 years or something. He was totally healthy. There was no symptoms. He initially had some URI-like symptoms, but he was RT-PCR positive for almost 2 months. So there is no anticipated timing for viral clearance, and critically ill patients will have more longer positive testing. And another thing is that decision for an elective tracheostomy should be taken only after discussion with the senior anesthetist and surgical team. And even the anesthetist is adamant on the point that the senior surgeon should come and do the tracheostomy. And the surgeon is adamant on the point that the senior anesthetist should be present when doing a tracheostomy in COVID positive patient to avoid confusion. And we used to have a dedicated team which was there in the plan, but right now there is no per se team. But we suggest that all those institutions should make a dedicated team They do all the tracheostomies in a week. That comes in a week, and for the next 1 week they go in for quarantine. When the next team will do the tracheostomy, and the coming subsequent week that team will go in for quarantine, and that will be actually very helpful. And the number of personnel involved should be limited. You should not have any extra personnel, and there should be a single dedicated team performing all tracheostomies on weekly basis. That is what we suggest to everyone. An experienced anesthetist and an experienced surgeon should be doing the procedure, and the operating team should be limited to one surgeon, one assistant, one anesthetist, one anesthesia technician, and one scrub nurse, or actually 5 person. And if required, floor nurse can be arranged. Otherwise, it would be better that things go like this. And another good suggestion that we came across, and we are right now following is that all patient-related records are maintained digitally. If there are problems with digitalization, what we do is we do not take the file paperwork of the patient into the theater. We keep it in a different room. And after the procedure is over, and after everything, after we doff ourselves, then we go and write the file. Or you can make a person who is not in the set group outside the operation theater to write the notes. The location where you should think about doing a tracheostomy can either be two places. It can be in a ICU where the patient is staying, provided it is a negative pressure ICU with adjacent waiting rooms. And tracheostomy or tracheotomy can be done bedside, so that avoids unnecessary transport and connection and disconnection of the ventilator circuits. Then ICU bed tracheostomy is preferred only if the infrastructure is available, because in ICU bed tracheostomy, not always we get that freedom that we get in the operation theater, and something goes bad, something starts bleeding. It will be very difficult unless you have a proper infrastructure in the ICU. If ICU tracheostomy cannot be think about, you can actually take up the patient into the operation theater. But the thing is, there should be a dedicated area and a dedicated route for patient transport if transferring into the operation theater. Now, what all you should be prepared with in the operation theater? If it is an elective case, it should be a last case in the list if it is elective. And there should be separate operating room for aerosol generating procedures. Not only tracheostomy, there are a lot of aerosol generating procedures, especially in otolaryngology. Whatever procedures you do in the nose, it is an aerosol generating procedure. Whatever procedures you do in the throat, it is aerosol generating. And even all those procedures which involve drilling of the bones. In otolaryngology, that comes as mastodectomy. For an orthopedician, each and every case that he touches, he'll be having drilling. All those will generate the aerosol. So there should be a separate OT room for that. And there should be a locker in the theater for keeping all the valuables of the surgeons, technicians, helpers, including mobile phone and jewelry prior to entering the OT. And all OT communication should be via intercom lines or separate OT mobile phone, because whatever said and done, our mobile phone is a big format. We keep it, we take it along with us, we take it along all parts of the hospital, wherever we go. And at the end of the day, we wash our hands, we bath ourselves, but we don't wash our mobile phone. We just change the cover, take it to our home, and give our child to play with it. What more can you do to spread the disease? So mobile phones should not be taken inside the operating room, especially in a COVID positive patient. Now, in the theater, there should be proper marked donning and doffing areas, and there should be proper training for all staff in as regards to what has to be done in donning, how has to be done in donning, and how it has to be done in doffing. And following doffing, there should be an intermediate area where you will remove your gown, your face shield, your shoe covers, and there should be another area known as a shower area where you remove all the rest of the clothing and get yourself and shower and come out of the theater. Now, this is one of the plans that we actually have implemented in the institution. That is, in the doffing area, first we remove the gloves, wash, then we remove the face shield, then wash, and we remove the gown. Then we go to the next room where we remove our hair cover. And this point is that we close the door fully in between the room before removing our hair cover. We remove the mask, and lastly we take a shower and we change the clothes and come out. Now, what all should be done inside the theater while the patient is on the table? Actually, decreasing the temperature in the operating theater is not actually very good for the patient because he may go in for hypothermia. But the other problem is that the operating surgeon, anesthetist, they all are in PPE. And once they get tired, mistakes happen. So keeping in mind the people wearing PPE, it is better to keep the AC at a lower temperature. And for many practical purposes, it is being said that there should be proper ventilation in the room and AC should not be put. But that is practically very difficult. So another opinion or another suggestion that we can put forward is that it should be a negative pressure operating theater, so that even though all those aerosolized products will not escape the room. N95 mask is a must, and now there is no question regarding that. N95 mask is must, everyone does that, and there should be no reuse of personal protective equipments. Actually, we still require better data regarding safety of how to reuse a PPE, how to reuse a N95, how far we can reuse it, how many uses can it be done. That there is no proper data available. And the proper PPE recommended is that you wear an N95 mask, surgical cap, goggles, or a face shield. Because especially people like me, I wear a glass, I wear a goggles, and I wear a face shield. I will see nothing in the table because it starts fogging. I cannot do anything. So what I do is I avoid the goggles, but I wear the face shield. If it is a person who doesn't wear a glass, he can have the both. That is the goggles and the face shield. Then the surgical gown, gloves, and better than, higher than face shield is the powered air purifying respirator, or PAPR, if it is available. Then the suction in the theater should be a closed circuit suction with a viral filter. Viral filter is a small thing that you can easily attach to it. Now, how do you transfer the patient? There should be, as I said earlier, there should be a dedicated route for transport. It should not be along where the bystanders are waiting or where other patients are waiting to enter the OP. There should be a different dedicated route for transport of these patients. And the transfer ventilator should wait in the operating room, and patient should be transferred as soon as possible after the surgery to the ICU. Because tracheostomy, give and take, it takes maybe after inducing maybe 20 to 30 minutes on the worst case scenario. And by that time, you should not send the trolley back and wait for it to come back after the surgery is over. Better let it wait in the operating room. Now, this is probably not my area, but being a part of the discussion, what are the anesthetic considerations in the theater that you should follow? One is that there should be complete muscle paralysis, which should be done for the already intubated patients, or monitored anesthesia care with local infiltration. Then you should actually advance the endotracheal tube safely below the inserted tracheotomy site to avoid cuff rupture. Otherwise, when we put the incision, we might directly actually poke the cuff and break it. And anesthetists should be asked to hold the respiration of the patient while incising the trachea to provide a better, safer perspective. Then muscle relaxation is a very important factor and has to be given again prior to incising the trachea. Because on incising the trachea, cuff is a must, and if you can avoid that, that will help you a lot. Then there is another thing that anesthetists use, that is known as THRIVE, or transnasal humidified rapid insufflation ventilatory exchange, jet ventilation, and positive pressure ventilation without a cuff tracheostomy tube are strongly discouraged, because all these produce high amount of aerosol. And backmasking also, we ask them to minimize. What we require for a COVID-19 patient for tracheostomy, what we require is that a well anesthetized, well paralyzed patient with no unforeseen incidents, so that we can be prepared and be prepared. Then the anesthesia circuit and ventilator circuit should be closed circuit with viral filter at patient end as well as at the machine end. and there should be no chance for an endotracheal tube disconnection, and should clamp the endotracheal tube in case of accidental disconnection. Now, how do we start the procedure pre-op? Just before starting the procedure, there should be a timeout, and we should ensure that all required equipments are ready and all personnel are ready, and everyone knows each other, and everyone knows what is going to happen. And begin the general anesthesia or the incision only when full surgical set is ready and the surgeon, assistant, and staff scrub and prick. This avoids confusion and decreases the skin-to-skin time. A range of non-fenestrated tracheostomy tube should be kept in the OR, and that can be replaced after surgery. We can ask the patients or the bystanders to replace it, because we cannot actually say which size fit the patient. Only on the table there is a rough calculation that number 7.5 is for the male and number 7 is for the female, but sometimes things may change. So it is better that we keep a range as a collection in the theater, use it on the patient and replace it after the surgery. And it should be non-fenestrated. There should be only one way of entry and exit, and that is through the outer tube. There should be no fenestra in the tube provided it is a COVID-19 patient. And there should be 2 separate high-powered closed circuit suction with viral filter to help you during the surgery for all those suctioning procedures. As I said earlier, the traffic in the operating room should be limited. Patient movement within the OT should be limited, and the number of OT staff should be only for essential purposes of being inside the theater. Then only selected equipments and drugs should be brought into the OT that we anticipate may be required for the case, to reduce the number of items that need cleaning or discarding following the procedure. Then single-use equipments should be selected wherever possible, or as I say, disposable equipments. Anesthetic monitors, machine surfaces are covered with plastic wrap to decrease the risk of contamination and to facilitate cleaning, because we just cannot throw those monitors or machines after each case. The patient should be reviewed, induced, and recovered within the operating room itself to restrict contamination to just one room. Or in other words, when the patient comes from the ICU, he directly should go to the designated operating room, where he should be induced, surgery should be done. And once after the surgery, till the anesthetist monitors, the patient is stable, that all should be done in the same room. And once he is ready to be shifted, he should go from that room directly to the ICU. There should be no waiting rooms in between. Now, procedure. What all things that we may require or we should think about during the procedure is that disposable equipment should be used whenever feasible. Avoid cautery. That is another thing. Cautery has a risk of aerosol generation, electrocautery, whether it is monopolar or bipolar. And we should prefer cold instruments and not tying for hemostasis. After the anterior tracheal wall is exposed, the ventilator should be stopped and the patient should be paralyzed, as said in the anesthetic consideration. And if needed, or if there is any doubt regarding the diagnosis of the patient, there is nothing more confirmative for COVID-19 than taking a tracheal swab. That can be done while doing a tracheotomy if needed. Otherwise, we can avoid that rule. And we should avoid tracheal suction as far as possible, because there is high risk of aerosolization. And the tube should be inserted with suction aid, which is connected to a closed continuous suction. And to review, what are we doing to reduce the time in contact with aerosolized secretions? We are giving complete paralysis of the patient to prevent coughing, stopping mechanical ventilation just before entering the trachea, and reducing use of suction during the procedure. Now, I'll brush through what is the procedure that we do during elective tracheostomy and emergency tracheostomy, and we shall wind this presentation up. During elective tracheostomy, we give complete paralysis of the patient before incising the trachea to ensure that there is no coughing or any other movement. And mechanical ventilation should be stopped before doing a tracheotomy. And we should withdraw the endotracheal tube just above the tracheotomy site or tracheostomy site, both are same. And tracheostomy is performed under direct vision without movement of patient. And tracheostomy tube is inserted, followed by inflation of the balloon. Now we connect the tracheostomy tube to ventilator, and when adequate ventilation is confirmed, we suture the tracheostomy tube to skin in addition to the tube strapping. Then we remove the endotracheal tube, return all instruments to the trolley, remove the face shield, outer pair of gloves, gown, and shoe cover in the intermediate area, not in the room. Then we leave the intermediate area with the standard precautionary protection, close the doors, and we go to the next room and remove our N95 mask and proceed to the shower area. Now, what happens in an emergency tracheostomy? Emergency tracheostomy has more risk because we are not prepared, anesthetist is not prepared, and we do not have much of a time. So that is where the mistakes happen. Emergency tracheostomy should be avoided as much as possible because the procedure will inevitably be performed under less optimal conditions than in the elective situation. Every attempt should be made to gain access to the airway through endotracheal intubation. In case of patients for whom difficulty of endotracheal intubation is expected, the surgeon should be notified in advance. And the patient and team should prepare, the doctor, I'm sorry for that typing mistake. It is the doctor and the team should prepare for cricothyroidotomy. The skin incision should be made down to the cricothyroid membrane, and complete paralysis of the patient is necessary to ensure that there is no cuffing or any other movement. An immediate incision of the cricothyroid membrane is performed with insertion of a cuffed tracheostomy tube of appropriate size. We cannot insert a large 7.5 tube. Whatever tube that we think will go through, we can insert it. Then that tube is connected into the mechanical ventilator, and we will wait until the patient's condition has stabilized on the mechanical ventilator. If it takes more time, if sometimes maybe half an hour or something, we can stitch the flange of the tube to the neck skin so that it is not displaced. Then once the patient is stabilized, we perform a separate incision for tracheostomy at the usual site, that is below the thyroid cartilage. And we identify the anterior wall of trachea, stop the mechanical ventilation before entering the trachea. Then tracheotomy is performed under direct vision with the patient paralyzed to avoid any movement. And tracheostomy tube is inserted, followed by inflation of the balloon. Then the tracheostomy tube is connected to the ventilator, and when the adequate ventilation is confirmed with proper tracheostomy, we suture it to the skin and do the strapping. Then only we remove the cricothyroidotomy tube and close the wound. Then the things are same. We return all instruments to the trolley. We remove the shoe covers, outer pair of gloves, surgical gown, plastic facial shield, all in the intermediate area. And we go into the shower area, remove our N95 mask, get a shower, and come back to the theater with a different edge. Then post-procedure, what are the post-procedure things that we can do? One is that post-procedure fumigation of the operating room. As I said, we usually post it at last case in the elective OT. So after that fumigation, there won't be any problem till the next day. Then there is increased risk of virus exposure in teams who perform suctioning, dressing changes, and other post-tracheostomy care. They have to be warned. They have to be thought of proper PPE, personal protective steps, and then only after getting proper training should only they do the procedures. And the cuff or the cuff should remain inflated, and we should intermittently check for leaks. And there should be make every effort not to disconnect the circuit, and only closed inline suctioning with viral filter should be used. And I had another slide over here. I actually that is what excuse me. This is what we usually follow in our institution. And this was what we made as a protocol, as I said, along with the help of my mentor, Dr. Suma Madam. And we had published it in our Indian Journal of Otolaryngology. That was the last slide, but due to some sharing problems, it has not been seen, the published article. So this is in concise how we proceed about tracheostomy. And the thing is, one is that we should know how to the proper donning, doffing of the PPE, and we should have proper indications when to proceed with tracheostomy. And emergency tracheostomy always carries a higher risk than elective tracheostomy. But things properly done, donning, doffing, procedures properly done, the risk is very minimal that the operating team or the care team will get COVID-19 infection from the patient. And I will wholeheartedly thank Dr. Mohammed Al Harbi, who has been contacting me for the past few months and asking me for the presentation, who has been very meticulous in his planning. And I do appreciate that things have turned out well. Thank you.
Thank you very much, Dr. Hafiz. It is an honor to be in touch with you. The beauty of this symposium is gathering all the scientists from all over the world to discuss the pandemic issue about coronavirus. It is a global concern for the physicians and the patients, or the population, I mean, in general. And of course, the tracheostomy is a major issue because you are in a minefield.
Yes, exactly.
So actually, your lecture is quite essential, quite valid for people who are working in ICU or in ENT, or in maybe in emergency conditions where you have to perform a tracheostomy. I am aware that fenestrated or non-fenestrated tracheostomy and how to apply them in elective or emergency conditions. But what about, as you see sometimes in trauma patients or in acute airway problems where you require intubation and the patient is dying? So sometimes even without corona, there are many challenges to perform a surgical tracheostomy or a needle tracheostomy. So what to do in case of the patient in a life-threatening condition? He's dying. So what to do?
We always have, as I said, in emergency tracheostomy, what we do is a cricothyrotomy. Cricothyrotomy is something that we with proper training that we can do from the emergency room itself. Not even you insert a tracheostomy tube, at least if you can insert a wide bore needle through the cricothyroid membrane, the patient will breathe. So in that movement, maybe we may not be, as you said, we may not be able to get a proper time for OT preparation, instrument preparation, wearing the PPE. But a simple N95 mask with a face shield and gloves will go a long way in protecting you from the COVID-19, because we don't know whether the patient is infected or not. But to wear a simple nowadays we all are wearing an N95 mask, and in the emergency department OPD we are wearing a face shield as rule. Just put a gloves, because why I say is that we had another study going in on our department. I'm not supposed to be discussing the details, but what we have found out is that a face shield N95 goes a long way in protecting you from getting a COVID-19 infection, even from when you're contacting a positive patient. So face shield and N95 will help you a lot. Even for an emergency procedure, you wear a face shield, you wear a N95. In the casualty, if you can get an airway access, well and good. Otherwise, go for a cricothyrotomy. Insert a wide bore needle into the cricothyroid membrane. Then you get a breathing space. We can think what you can do next.
What about the tracheostomy care after, let's say, a patient who is long-term in the ICU and you're required to do, and he's infected with COVID-19, and you are forced to do the regular tracheostomy care like suctioning or replacing the tracheostomy tube. So what are the precautions in case that you are forced to do suction in a patient with COVID-19? So what are the solutions?
There is actually, as you said, we are forced to do everything. Following a tracheostomy, there should be proper tracheostomy care, there should be proper suctioning, there should be tube change. All these has to happen. Few things about that is that the suction that you should use should have a viral filter. And whoever goes near the patient should be in full proper PPE, full the gown, gloves, mask, face shield. And the third thing is that previously, we used to after a few days, if the patient is breathing okay, and not when connected to off the ventilator, we deflate the cuff. That is actually not recommended in a COVID-19 patient. It is better to keep the cuff inflated. And tracheostomy tube change, and when I went through to prepare my article, it was said that tracheostomy tube change should only be thought after the patient is COVID-19 negative. What we have seen is that sometimes COVID-19 positive patients, God forbid, but happens so that once he gets a tracheostomy on ventilator, if he continues to remain positive, we may not be able to revive the patient back. If he is getting better, he will automatically become COVID-19 negative. So when he is negative, we can think about a tube change, but all the other things, suction with a closed suction and a viral filter, we will have to do. And this thing, tube change as is that, and the staff, nurse, all should wear proper 100% PPE and should contact the patient. And sometimes unexpectedly the tube may get expelled out. At that time, we can, if it is a tracheostomy that has been performed 1 or 2 weeks earlier, stoma will be there. We'll get a little bit more time to put the tube back. And another thing is that we can always use an inner tube for all the tracheostomy. Even Portex tubes get an inner tube. If you put an inner tube, tracheostomy block can be very well managed by removing the inner tube and properly washing it.
Last question. Any question from the audience, please? Last question from me, because the tracheostomy is something, as I told you, it's like a minefield. So we have to be very careful dealing with tracheostomy. The last question, the filter type, how to make sure that the filter that you are utilizing is meeting the specification and it's smaller than the size of the coronavirus. I think that the size of the coronavirus is something like 60 nanometer or something like that. So is there any specific or scientific quality control to make sure that this filter is really working to prevent the transmission of the virus?
I'm sorry, but I haven't gone to that details. We have an infection control committee in the hospital. They approve the viral filters which come. So I'll get back to you. I'll contact them. I'll get back to you as to what they are doing to approve the what is that size criteria they are keeping as a cutoff to approve it as to be used in the ICU. I haven't gone into that detail. I'm sorry, but I'll get back to you with that detail maybe in 1 or 2 days.
Thank you very much, Dr. Hafiz, for your joining us. It is really a pleasure. I'm so happy actually to have a meeting with you and to present your nice lecture. And hopefully we can share in the future more cooperation. Thank you very much. The next speaker is Dr. Muhammad Suleiman. How are you?
How are you doing?
I'm fine. It is really a pleasure. This is Dr. Muhammad Suleiman. He's a lecturer in Cairo University. He was a fellow of neurosurgery in Canada. And it's really an honor to be in touch with you and to present your lecture. Thank you very much. Please proceed.
Thank you. Can you see my screen? Can you see my screen or?
Yes, go ahead. It's showing up. Yes, thank you very much.
Okay. So good afternoon, everyone, or good evening, good morning. I'm Mohammed Solomon. I'm neurosurgery lecturer at Cairo University and clinical fellow at Western University, and currently I'm working in the US. I'm gonna speak today about the impact of COVID-19 in neurosurgeons worldwide. This lesson learned early in the COVID-19. And first of all, if there is any brain manifestations or infections to the brain from the COVID-19, there is a paper published in JAMA Neurology on neurological manifestation of hospitalized patients with coronavirus. And quickly there was, of course, it was more in the severe cases CNS manifestation was dizziness, headache, was 25%. However, recently they found that also there is association with stroke, especially in young patients due to hyperviscosity. Also, peripheral nervous system, there's impairment of sight, smell, taste. Of course, the most common is the smell. Recently, they found due to infection passing through the cerebriform plate, and then skeletal muscle injury, they found the creatine kinase elevation. This work was like a multi-center help from, as you see, Cairo University, Western, Harvard, Barrow, University of Illinois, Indiana, and also Jamiat al-Qasim University from Saudi Arabia. So there's a lot of contributors to this work. So quickly, the introduction was like the coronavirus pandemic has affected virtually all aspects of human existence with social, psychological repercussions that generations have not witnessed. It has devastated the world economy through massive layoff, business disruption, and collapse of financial markets. Education and research at all levels has been suspended, and day-to-day interactions have changed as the virus is projected to affect large portions of the world population. Our aim was to study, provide a snapshot early in the COVID-19 pandemic that hopefully provides some insight into how nations are dealing with this crisis early and how we may learn from each other and improve future responses if hopefully no pandemics coming, more pandemics are coming. So our study design, we obtained a neurosurgeon's contact information from professional associations, social media forums, Facebook, Twitter, WhatsApp, and through interpersonal contacts. We also utilized open access social media-based surveys through neurosurgery groups, Facebook and Telegram. And we collected the data, as you can see, early in the pandemic from March 20 to April 3rd. The survey was translated into 7 languages: Chinese, English, Italian, French, German, Portuguese, and Spanish. And the survey was administered through Google Form and WeChat for the Chinese colleagues. All responses were collated with Excel and cross-verified by 2 members of our team. And the survey was formed of 20 questions. It was a 4-minute survey, including demographics, perception and knowledge, clinical impact, hospital preparedness, cost, personal affection. We used chi-squared and logistic regression analysis. And as you can see, we were covering most of the world countries. We had a 791 response from 85 countries. And so you can see it was covering all the world, mostly from region of Americas and European, taking up to 60% of the responders. World Bank income, 35.4% from high income, 36.7% from high middle income countries, and around 28% from middle income and low income countries. The COVID caseload was, as you can see, it was still early in the pandemic. It was mostly 151 to 1,000 cases in their country. And the demographics, most of them were general neurosurgeons, according to specialty. The practice setting mostly was also either government or hospital employed. Perception of seriousness of the COVID-19 pandemic, we were asking them if this is a minor issue and there is an exaggeration of the seriousness of the disease, major issue, a crisis. I didn't have time to learn about the disease. And you can see, surprisingly, this was early in the pandemic, 4.4% wasn't knowing anything, and they're thinking it's a minor issue. The COVID-19 knowledge, the source, also you can see around 20% their knowledge was through social media and TV, and only 43% of the neurosurgeons that responded to the survey where like their source of information was scientific publications. Elective clinics and surgeries cancellation, 57.5% were canceled in the private practice, 51.9% in the government practice. And the reason for elective cancellation was mostly government direction. However, there was still patient preference and physician preference to cancel, not the government directing this. Dealing with elective clinics, so 47.6% canceled till further notice, 20.9% postponed, and 22.9% changed to video telephone calls, and 7% changed to video conference or teleconference. 45.7% of the neurosurgeons that responded said their hospital were insufficiently prepared, and 20.6% were saying it's well prepared. PPE utilization, 35.9% was regular mask and gloves, 40.3%. However, you can see here that there's around 12% they were not using any PPE while dealing with the patients. Supply cost mostly was no change. However, there's 12.1%, mostly in the Americans, there was increase in the OR supplies price. 71.4% perceived that their workload decreased, however 12.4% were increased. 62.5% of the neurosurgeons that responded to the survey had a financial burden due to COVID. And regarding the scientific and research activities, you can see here like 50.4% of the scientific and education activities were canceled versus 26.7% were in the research activities. We asked them about what should be the role of the neurosurgeons to show solidarity against COVID pandemic. And most of them were saying it's like either institutional level or the organization level. Only few mentioned it should be on the national level or the international level. So comparative analysis, when we use the logistic regression model, and for the students who don't understand what's this curve, this is a called force plot curve, where this line, if it's, so it measures the odds ratio and the confidence interval. And if the bar is on one side of this dotted line, this means it is significant and it's directing toward one side. So you can see here that the perception, the people that was perceiving it's like a major issue was more that their workload was increased versus the people who was perceiving it as a minor issue, the workload was decreased, sorry. Here you can see the source of information. The African were more likely to look at their source of information, social media news, also compared to the Americans and European. Also, the high income countries were having high odds that they are looking in scientific publications versus low income countries. Hospital preparedness, as long as more the case load was increasing, the people that responded were like perceiving that their hospital are less prepared. Government and private setting versus people that working in both groups. African and low-income countries, of course, were finding that there is less hospital preparedness. Elective clinics and surgery, it was canceled more in the non-African countries, 50% versus less than 50%. The cancellation, like directed by the government, it was more when they are perceived, like the surgeon was perceiving it as a minor issue, as more the caseload, and same it's here as caseload. Reason for cancellation of elective clinics in the private practice. So you can see here, it's more with as long as it's more the caseload. Same here, it's same private versus governmental. So government was more to cancel the cases. Dealing with elective clinics, telemedicine. So if the hospital were well prepared, so it was more likely to use telemedicine. Perception of as a major issue also was likely to use as a telemedicine, sorry. Upper and high income countries were more likely to use telemedicine compared to canceling and postponing the cases. Also, OR supplies, as I mentioned earlier, the Americans were having more costs, increase in the cost supplies during the pandemic. I'm speaking about the neurosurgery, like screws, cages. The PPE utilization, as more they are perceiving it as a major issue, they were using the PPE, also as the caseload increased. Low-income countries were significantly less utilization of the PPE. Financial burden, general neurosurgeon was less likely to have a financial burden compared to the spine and peripheral nerve because these are more elective cases. Also, the government were more likely to have more burden, as also if the hospital is less prepared, so it will cause more financial burden on the neurosurgeon. And high income country compared to low income country also were significantly having, sorry, the low income countries and lower income countries were significantly having a more financial burden compared to the higher income countries. Scientific and education activities, American and European, were significantly affected by the COVID pandemic in regard to scientific education. This is more likely because they have more conferences than our countries. So that's why maybe they perceived it as affected more than 50%. There's research activity, we didn't find any significant difference between the variables. So conclusion, our survey provided insight of the COVID-19 pandemic. Early in the COVID-19, we found that many neurosurgeons lacked credible knowledge and their institutions were inadequately prepared. This has resulted in a paralysis of healthcare delivery that has harmed patients. As we move forward, we must learn from our mistakes so we may be better prepared. Global healthcare initiatives have already proven successful with HIV and malaria, empowering lower income countries to proactively contain these epidemics has wider implications for global healthcare security. In 1980s, such initiatives in Africa to combat AIDS were quickly translated to combating Ebola in 2014 and 2016. We all have benefit from such programs. We encourage increased resource allocation for better pandemic preparedness in the future. Neurosurgeons must develop disaster strategies to attack future crises through collaboration and communication that has never been seen before. And this work was published in Neurosurgery. Regarding reopening of elective surgeries, I don't know what's the situation in Saudi Arabia now, but now Canada and in the US now nearly we return to the new normal. However, we pass through these steps. Stage one is controlling the spread. Okay. So in anticipation of hospital overcrowdedness from COVID-19 patients and to contain the COVID-19 spread, worldwide authorities are going to delay all elective surgery, as you saw from our study. In an effort to control the spread, most neurosurgery departments have adopted protocols triaging their currently scheduled cases, canceling non-urgent elective surgeries, and limiting their clinics or using telehealth visits to facilitate social distancing mandates while continuing to treat the patients. Face-to-face patient care is limited to wound care and emergent ER evaluation only. These measures are anticipated to remain in place as transmission measurably slowed down and infrastructure is reestablished to safely manage care of patients. And patient triaging was depending on the pathology, neurological status. Of course, pathology, the higher the, for example, highly malignant brain tumor patient was cauda equina, patient having weakness in their legs, This is a pathology that was mandating urgent surgery. Neurological status, if there's weakness, disturbed conscious level, other comorbidities. If a patient having like a lot of comorbidities, we adopted not to do surgeries because they are higher risk of getting COVID-19 and mortality from this. COVID-19 is that positive or negative. Outpatient versus inpatient. Outpatient were more likely in the next stages that we used it so as to save the hospital beds for COVID-19 patients. And these are some like triaging from different organization. This is the Deutsche organization, sorry, the Society of Neurosurgery in Germany. So this was for urgent surgery: malignant brain tumor, metastasis from any primary tumor, benign or low malignant with relevant parenchymal compression or increasing neurological deficit, pituitary tumor with cranial nerve deficit, visual disturbances, or endocrinological malfunction, which cannot be controlled conservatively. And this is a very high risk of transferring like the COVID-19 skull-based surgery, because like the virus is loading in the sinuses. Also, is not only the transsphenoid surgery, it's also the mastoid surgery when we're approaching skull base laterally is also high risk of getting COVID-19. So we were adopting this only in case if the patient is having endocrinopathy or cranial nerve deficits. Neurovascular, subarachnoid hemorrhage, malignant stroke, large intracerebral hematomas, ruptured AVMs, AV fistula, eminent rupture aneurysm, traumatic brain injuries, acute cerebral trauma, subdural, epidural, increased intracranial pressure, chronic subdural hematomas with neurological symptoms. And this also from the North American Spine Society, you can see also if it's limb or life-saving. So if the patient is having progressive or severe neurological deficit due to neurocompression, spinal instability, epidural abscess, or post-operative wound infection, these are the patients that do not postpone. Okay, urgent, it's a progressive but not as severe as these ones. Elective were all canceled. So stage 2 is recovery. Before stage 2, we have to trigger the end of stage 1. The hospital must approve, like they know what's their like supplies and how they can accommodate like the new doing surgeries on the postponed cases. This is another pandemic because there's after the cancellation, after the early COVID-19, there was a lot of patients suffering, and then after the reopening, these patients rushed into the ERs and into the hospital. And this is another pandemic of patients, not COVID-19. A sustained reduction in COVID-19 cases is seen for at least 14 days. The associated hospital system is safely able to treat all patients needing hospitalization without resorting to crisis standards. Rapid testing is widely available to all patients and providers. Then recovery. So recovery, there's goals of stage 2. Relax physical distancing measures and reopen the offices in careful fashion to prevent return to stage 1. Triage the sickest or most at-risk patient awaiting semi-urgent or elective surgery to ensure treatment in a timely manner in the event of return to stage 1. Position the neurosurgery department to have high priority of access to OR availability. Restructure sophisticated education experience for resident students and patients. Reinvigorate research efforts. Constant reassessment of the new normal in anticipation of transition to stage 3. You have to ask ourselves these questions while reopening in stage 2. Which way to start? Should we do the inpatient surgeries, same-day surgery? What about our ICU beds? Like, for example, a brain tumor, this patient will need even if it's elective, this patient will need an ICU bed after. Do we have available ICU beds? All of these questions we need to ask ourselves. Are we gonna do a teleconference consultation or in-person, face-to-face? Here in the US now, we already doing the face-to-face. There's some hospitals are adopting teleconferences. However, for me, neurological examination need to be done. PPE, and who will use the PPE? Are we gonna use just a face mask, double waterproof gowns, PPE-AR, or like just the N95? Is the workforce available? In the COVID-19, we used to like half of the team working and the other half at home for 14 days, and then we are moving so as to decrease social distancing. Facility considerations, sanitation protocols. Facility consideration mean the availability of the rapid testing of the COVID-19, and also there's programs that were downloaded. It was very tough for the family of patient having a brain tumor that his family is not able to be with him during his stay in the hospital. So there's some programs where apps on the phone that were allowing the family to be like in contact with the patient all the way through his stay, and also the nurses were like recording 1 or 2 minutes with the progress of the patient, so it was recorded and the family can know what's going on with the patient. Then stage 3, our new normal. We will never return to our previous normal. Stage 3 involves the lifting of all physical distancing recommendations and depend heavily on the development of effective methods of prophylaxis and treatment. We have currently identified these goals with an explicit understanding that times are changing rapidly and that our responses to the pandemic remain fluid. The specific milestones and suggestions include, in this report, our judgments based on our current understanding. As we have seen, this can change rapidly. Importantly, we believe that recovery following the COVID-19 pandemic offers a unique opportunity to disrupt and rebuild the historical patient and office experiences in a modern post-COVID-19 world. I would like to thank Dr. Al-Harbi for all of his effort to get this magnificent program and magnificent webinar to the Saudi colleagues. He was working hardly to get this fruitful event. Thank you.
Thank you very much, Dr. Muhammad. It's really an honor to be in touch with you. The beauty of this symposium actually is to gather the experience all over the world from different countries. And the real gain actually is to have people like you and like the other colleagues, that our friendship is the most valid thing. I'm sure that your contribution is quite essential, and it is my pleasure to have this group of colleagues like you and the others from different countries. For sure, COVID-19 has never happened before, and it makes a major challenges for the health care providers. And one of the main goals, actually, as I explained yesterday, that there is actually no proper umbrella for the medical staff and how they control such pandemic globally. Usually the guidelines comes from the department or from the hospital. Many times it's based on evidence-based, but sometimes it is not. But I'll come to my question. As you know, here in Saudi Arabia, one of the most serious things is the head injury, the neurosurgery head injury. And in many hospitals, they occupy almost 30% of the hospital bed capacity. So what do you think? Maybe if you are in States or in Canada, maybe the issue is different. What is the rationale? Although we are back now to normal here in Saudi Arabia, but what is the rationale now in US and Canada about managing head injury patients, and you are not sure is he COVID-19 or not? Either he's positive or suspicious or asymptomatic. I mean, he's negative. So what to do in such condition of trauma patients?
Yeah, so trauma patients is different. So till now, there is no specific pathophysiology that they found that why the COVID-19 are sometimes found in the CSF. So as long as you're not opening the dura, you will deal with the patient. Anyway, you will deal with the patient if you don't know the situation of the COVID-19, you will deal with him as if he's COVID positive, okay, until proved otherwise. The high risk surgeries are the surgeries that you open the dura in, okay, because it's the CSF. There's several case reports that they found there's in the RNA for the CSF, they found COVID-19 RNA in the CSF. So you will deal with all the patients that you're opening the dura as a COVID positive until proved otherwise. Okay, wearing N95 or PAPR, which is the purified airways respirators, double gloves,
N95.
Yeah, or N95, water resistant gowns. So any patients, you will deal with them like this. Of course, there's high risk surgeries that you're dealing with the mastoid or like the air sinuses. So these cases, you're trying to avoid the drill, because the drill, they found that it caused aerosolization of the virus in the air and increased the risk of COVID-19. There's early experience in one of the hospitals in China, in Wuhan. They found when they diagnosed this, they found that 14 staff that had a patient had a surgery, transsphenoid, and 14 staff were infected with COVID. So, and they started to look into that, and they found that there is aerosolization of the air as you're using the drill. So in the skull-based surgeries, mastoid or the transsphenoid, we usually try to use either kerosene, chisel, like no drill, so as to avoid this aerosolization. Okay. So in trauma, like in the trauma, the only one that we mostly is the frontal sinus repair, which can cause CSF leak. Otherwise, anything that you're opening, you're dealing with it as like full protection. Otherwise, you can wear just a N95 or double mask and treat the patient.
The second question, I think there are some reports about some neurological manifestation or complications secondary to COVID-19. So any idea, any clue, any suggestion about that?
There's recently published study on the COVID is passing through the sinus through the cribriform plate going into the CSF. However, the major studies now are mainly on the hypercoagulability and the high risk of stroke, especially in younger patients with COVID. It's because of the hypercoagulability, but there is like higher incidence of stroke in younger patients who had COVID positive, which is more.
But those patients, do they have a special management algorithm different than others, or they have?
So they are managed as stroke, thrombectomy, like normally, like TPA thrombectomy, but it needs a high suspicion. Like when it's coming more in the ERs, younger patients with stroke, and they are managed as usual. To my knowledge, I'm more spine surgery, but to my knowledge, in the meetings, that's what's going on.
The last question, do you think that drilling with orthopedic surgery, is it the similar idea of the drilling of the mastoid for neurosurgery? Do you think they must have the precaution like the mastoid drilling?
We don't. We in the spine surgery, for example, we are not afraid of that, because we are not dealing with like, as I told you, the CSF, which is having more from the sinuses. But I think early there was some precautions mentioned, especially in the skull, that's not touching any CSF. We're also trying to trying to wear everything when you're drilling even the skull.
Well, thank you very much, Dr. Mohammed. I'm really happy and grateful for your presence, and we will be in touch again soon. You are, a very close friend and a new friend, so thank you very much for your contribution.
Thank you so much. Have a good day.
Thank you. We will be back. We will have a 20 minutes break. We will be back in 4:30, and I think Dr. Goro, he will make a presentation. So we will have a 20 minutes break. Dr. Ogo, your voice is not heard.
Oh, thank you.
Oh,
Thank you
how are
for the
you?
invitation. Hi, Mohammed. Good.
Nice to meet you.
Fine. Thanks. Nice to meet you.
It is really a pleasure to have you in this event, and Dr. Santoro and you, both of you are welcomed in this event. Dr. Ogo Grossi, he's a research fellow in Queen's Mary University in London, United Kingdom. He is a well-known researcher, and he has a lot of publications, and he's a colorectal surgeon. Is that right, Doctor?
That's right, absolutely, Mohammed. Thank you.
Yes, so please start your presentation.
Okay. Do you all see the screen?
Yes, it is, yes.
Okay.
Go ahead.
Wonderful, sorry. So I'm going to talk you about a hot topic during this time of the pandemic, the efficacy of telemedicine in managing non-COVID-19 patients. So a universal agreement exists that elective surgery and outpatient clinics should be delayed during the COVID-19 pandemic to reallocate hospital resources, expand the number of ICU beds, reduce personal protective equipment. So telemedicine and remote consults have become popular during this time, although it existed before the pandemic. So this is an example of what, for a benign disease such as hemorrhoidal disease, the delay, the effect of a delay in treatment with a large thrombocyte pile in a 70-year-old man. Telemedicine arrives in the UK and has been defined as 10 years of change in 1 week. This is how the New York Times defined telemedicine. We know that previous work has specifically described the potential for using telemedicine in disasters and public health emergencies. No telemedicine program can be created overnight, but US health systems have already implemented telemedical innovations in response to the COVID-19 pandemic. The American Medical Association reported a 53% growth in telemedicine provision between 2006 and 2016 and 2017. We know that telemedicine is defined as the use of communication technology to provide support, health, and at a distance. Telemedicine was first conceptualized in the 50s, but the widespread use was hindered by the lack of access and technology. The utilization of telemedicine has rapidly grown as computer and smartphone technology have become pervasive. This is used sometimes as a synonym of telehealth. Telemedicine is used as a synonym of telehealth. Describe the delivery of remote clinical services, including diagnosis, monitoring, prescribing therapies by means of ICT. There are several reports on the use of telemedicine since the start of the pandemic. So we have been observing an exponential growth in publication with regard to the use of telemedicine in health. In this example, this is a very good example of the use of telemedicine in the field of IBD and specialist nurses. In this study, 88 patients were seen during 2016-2017, median age 46 years, and the majority of patients were between 19 and 65. Follow-up video conference clinic was required in 92% of appointments. Tests ordered included requesting, for example, fecal calprotectin in 48% of patients, routine bloods in 38%, endoscopy in 9%. The did not attend rate was very low, 2.6%, and the mean planned time until the next video clinic appointment was 4 months. This is another example of the use of telemedicine as a follow-up for stoma patients. In this study, including 110 patients, randomized to hospital 58 or teleconference 52 follow-up. 64 patients were followed for more than 12 months and 246 consultations were performed. They did not observe any difference in quality of life, work social function, sexuality, body image, and stoma function. Hospital follow-up performed better for organization of care in terms of staff collaboration, met the same person, communication. Teleconference did not increase the number of hospital consultations and reduce the number of journeys to more than 8 hours. In this other example, in this study, the author tried to determine patient preference in choosing the preferred contact modality for regular outpatient follow-up. Out of 50 patients who were willing to able to participate, 21 patients indicated to prefer a video consultation, which is slightly below half of the cohort. Patients who use video calling in their personal life chose a video conference significantly more often than patients lacking this experience. And as previously demonstrated by other authors, the effectiveness of teleconsultation in terms of grade of satisfaction and perceived quality of care during follow-up in colorectal cancer patients is very evident. This is a recent study we have published on Surgery Journal involving 48 experts nominated by the Italian Society of Colorectal Surgery on the basis of both previously published research in the field and clinical experience in the field of proctology and pelvic floor. So a consensus exercise was performed, scoring a series of items on a linear analog scale from 1 to 9, where 1 is risk exceeding benefits, and 9 is benefits highly exceed risk. So 1 is very inappropriate and 9 is appropriate. As you can see, telemedicine is a useful tool to estimate the quality of life of proctological patients for scientific purposes. This statement reached a high consensus. Telemedicine reduces the distance to areas that are difficult to assess or geographically distant. This statement also reached high consensus. And in another statement, the cost of teleconsultation should be lower than that of conventional consultation. This also reached quite a high consensus among experts. In this study, Nizar and colleagues have developed a telemedicine-specific checklist for surgeons to quickly onboard patients into this unfamiliar visit modality, defining comfort and expectation and reducing the risk for technical errors and privacy violation during virtual encounters. So there are undoubtedly strengths of telemedicine, which basically consist in continuity of care, digital divide in rural areas, reducing the digital divide in rural areas, and cost effectiveness. But there are also limitations in terms of possible existence of a digital divide in patients, concerns on reimbursement, licensing, and fear of litigation, difficulty in using the system or lack of user-friendliness, and ethical issues with transparency, privacy, and confidentiality. This is a very, very nice reading, which I recommend. In Oslo, some of you may know this, in Norway, there is a the biggest temple of sports, the Bislett Stadium. This stadium is where 65 world records have been set in sports, including speed skating and track and field. It hosts such grand events, including the Bislett Games, the European Championship, and the Olympics. The construction of this stadium was such that the seating was designed to permit the spectator the opportunity to be very close to the contestants. The seating was very steep. The competitors on the 6-lane track are literally next to the seated and enthusiastic spectators. The noise of 21,000 cheering and adoring fans resonated with the athletes in ways that enhanced their performance through encouragement. The crowd actually made the athletes perform better. They performed better because the venue was electrifying. The athletes' confidence builds because of the cheering. This has become known as the Bislett effect. And the implication is that we are not alone in our quest. There are supporters out there rooting for us. You might be asking, what does this have to do with healthcare and telemedicine? Let us review. Running can be a metaphor. We run because we like it, and it helps us get somewhere faster than walking. While it is good for our health, it can also be challenging. Anything we do in our lives can be challenging. If we cheer on one another, we do better. Our performance is better because we are not alone in the race. And so I hope you enjoyed this presentation. And this is the stunning view of my hometown, which is far from where I work now. But yes, I want to leave you with this. Okay, thank you for the attention.
Thank you very much. Thank you very much, Dr. Ugo. Personally speaking, I think telemedicine has some future, personally speaking. Especially it's not also pandemic. Sometimes even sometimes regional wars or regional disasters, or tsunami, or etc., or earthquake. So the telemedicine, my personal belief, it needs some investment and research, especially that it can provide the experience. Sometimes you have a staff who is a junior staff or an expert staff in location A, but you have an expert staff in location B. And the idea of robotic surgery started this way, that you can transform or you can transfer your skills and knowledge over the satellite to a different location. So it is a combination with an old technology, which is the robotics. So I guess in the coming few years, the telemedicine require from the scientific society more elaboration and more discussion about the limitations which you discussed in your lecture, like the privacy, like the security, like the legal aspects, the limitation. We do telemedicine, but you cannot do tenderness assessment with the telemedicine. You cannot do a palpation of a mass, is it getting bigger or not? You cannot evaluate presence of ascites, is it getting smaller or bigger? But you can take a proper history, you can do inspection. So maybe my personal belief that this is a good area for research. Once we reach this physical findings limitations between the two sides, the physician or the expert physician in location A, and the unexpert physician or the patient alone in location B, I guess the telemedicine, if invested properly by research in the coming few years, it will come to a good location. But my question here is, do you think that telemedicine can solve all surgical problems, or do you think it is only for selected type of patients?
Yes, this is a very good question. I agree with you. Societies, international societies should better elaborate the concept of telemedicine, and the scientific progress should move hand in hand with the development of telemedicine by expanding in indications. For now, my personal view in the surgical field is that the physical barrier to objectively assess patients make telemedicine very limited, especially for first assessment. So for selected patients, as a matter of follow-up evaluation, I think telemedicine during the pandemic is a great opportunity to push. So I made an example of stoma patients. In stoma research is the only field where we do have high quality research, so randomized controlled trial. For other scenarios, studies are very limited and with no such a high quality. So technological improvements should definitely go hand in hand with the development of telemedicine and moving the boundaries of telemedicine beyond and beyond. This is my view on this.
Okay, that's nice. But what about surgical interventions? Let's assume that in an isolated area in location A, and it is complete quarantine, complete lockdown. Nobody can go in, nobody can go out, and the surgeon is, or the junior surgeon, or even the primary physician is forced to perform an emergency surgery like wound or maybe simple surgical procedure. Do you think the telemedicine would be able to enhance the skills or the primary skills of the lockdown physicians by telemedicine? Do you think it is an option?
It may be an option, and I'm sure that with the advent of the 5G technology, as already demonstrated with surgeons peeling a banana or an orange from thousands of miles distance, might definitely be something we will see in the future. So in terms of reducing the distance and offer an opportunity to local isolated cities in a time of a pandemic can definitely be something that we will see in the future, definitely.
My last question, as you see, you are in the West and you are the nearby by the companies who prefers to do research, to invest in the future. Do you think the entrepreneurs from companies in Europe and United States, do you think they are willing to invest in this technology for future telemedicine, or it is only because of the pandemic and it will go back again to its normal location?
No, I'm firmly convinced that we won't go back in terms of our view, as the pandemic has dramatically changed our view on healthcare. So I'm definitely convinced that telemedicine, the development of telemedicine, will continue also when we won't wear masks, and we will start to hug again. Telemedicine will definitely be a parallel opportunity for delivering healthcare, definitely.
Very good, Dr. Ugo. I'm really appreciated. The beauty of this event is to meet people like you, pioneer and experts and researchers. So thank you very much for
My
joining
pleasure.
this event, and I'll be in touch with you soon to discuss few issues. Telemedicine is something going on. It's growing up. It is an area of improvement. I believe you already explored this area, so thank you very much.
Thank you for the invitation.
Thank
Bye.
you. Bye. The next lecture, I think. 1 minute. Our topic today is about clinical course and outcomes of critically ill patients with COVID-19 infection. The main issue here is, or the main reason of this lecture is that hospital admission and challenges that face the intensive care unit stay, which is quite essential to understand what are the consequences and what is the course, what are the outcomes of COVID-19 pneumonia in critically ill patient. This review, it includes about 69,000 patients in the ICU, and briefly demonstrate that infection in critically ill patients is associated with a great need for life-sustaining interventions, high mortality, prolonged length of ICU stay. So a more comprehensive knowledge of ICU utilization is quite important, and the outcome also would be potentially helpful for healthcare professionals and the managers to estimate the need for ventilators and ICU bed and the dialysis monitors, and to manage more adequately their staffing patterns. These findings have significant implication for a better understanding of the epidemiology of COVID-19 and for a better planning and organization of the hospital and ICU to ensure better preparation and optimization of delivery of care under pandemic circumstances. And despite numerous reports of critically ill patients, the outcome and the clinical course of and also the intervention of patients who's going to be admitted to the ICU is still unclear till recently, owing to the differences in design, patient population, geographic reasons. There is a large variation among studies in the ICU admission rate, morbidity and mortality for COVID-19 patients. Moreover, patients with COVID-19 often have severe presentations and multi-organ failure and require life-sustaining interventions for basic care. There is a need for highly skilled staff and more sophisticated and expensive interventions such as invasive mechanical ventilator, or extracorporeal membrane oxygenation, ECMO, and renal transplant therapy, RRT. In current review, a systemic review has been done with the aim to describe the clinical course and intervention which is used and the short-term outcome of COVID-19 pneumonia requiring ICU admission, and data source and selection. It has been conducted through a systematic review of literature according to the recommendations of meta-analysis of observational studies in epidemiology. Also the following primary research terms or key words in the midline It includes COVID-19 or SARS-CoV or coronavirus. So there was no language restriction. The literature search was performed from the 1st December 2019 up to 15th August 2020. Preprint were searched on the site of preprint.org using the following terms: COVID-19 or coronavirus. Reports were also searched manually and were included if they met the inclusion criteria. The most recent search was performed in 20th of August 20. The reference list of retrieved articles and relevant review articles as well as personal files were manually searched, and it was considered that the following criteria for the study inclusion is full text, prospective, retrospective, or registry-based publication, and patient admitted to the ICU for COVID-19. Or studies including patients diagnosed with COVID-19 using a validated test, and studies reported an association between COVID-19 and at least one of the following outcomes, which is death at any time, length of stay in the ICU or in hospital, duration of mechanical ventilation, and occurrence of acute respiratory distress syndrome. Letters to the editor, individual case reports or review and the studies could not be and should not be reported in this review. Standard investigators have processed this review, and the selection of potentially relevant titles for review of abstracts, and among them of those chosen for review of the full-length reports, all selections were decided by consensus that this report was prospectively registered with Prospero database. Data extraction and data quality assessment, data extraction from the selected articles was independently performed by two authors. The following data were recorded when available, and the study characteristics like study and selection of patients, number of patients enrolled, patient characteristics and outcome. Also, it has been considered that the center had ICU according to the description of each researcher. The data were not available to allow another classification, or to allow further classification has not been considered, and it has been reported that some description of the ICU and high dependency unit together and same analysis should be considered. To assess the methodological quality of the studies, it has been adapted that Newcastle Ottawa Quality Assessment Scale, which will give a better description to the risk of bias in our systematic review. Analytical approach, it has been evaluated COVID-19 patient characteristics and the main outcome described. It had been special interest that describes mortality, length of hospital stay, and intervention, and the type of the intervention used. For continuous variables, we described the confidence interval based on the reported data.
Yeah, the patient is worshipping now after 10 minutes.
Described with the numerator and it has been used that SPSS to analyze the data.
When I am guys the leads, you can manage this thing.
The other one male patient with this one with inotrops already shifted in bed 18, 60, bed 18. Because I saw the ECG. Yeah, partner now. The one from other hospital. We're shifting now after 10 minutes. ICU, bed 25. The patient already there. Yeah. 10 minutes.
لو سمحتم يا اخوان الصوت لو سمحتم يا اخوان.
الله اكبر.
For that patient.
المايك يا مشاركين، المايك لو سمحتم.
الصوت لو سمحتم يا اخوان.
يا احمد اغلق المايك اللي ناسي.
The literature search yield 2,927 studies of the 320 potentially relevant abstract screen, and 47 articles were available for detailed analysis. Finally, 32 articles that met the inclusion criteria were included in this systematic review. A flow diagram is available to show such results. Study characteristics. The characteristics of the 32 included studies are shown in the paragraph, and the 28 studies and 5 non-peer reviewed reports from the National Registry on Research Group. A total of 69,039 patients were admitted in the ICU and were evaluated. Most studies were performed in China, but they represent only 1% of the ICU patient described. Reports from a National ICU Registry and the research database included the largest number of patients in analysis. The follow-up periods of studies ranged from late December 2019 to 15th August 2020. 17 cohort studies evaluated hospitalized patients and described patients who needed ICU admission. 9 cohort studies included only ICU admission, only ICU patients. Only 1 study described 28 mortality, and no studies described long-term outcome after hospital discharge. The studies reported different results regarding symptoms, time to critical illnesses, clinical course, development of organ failure, intervention used, and short-term out for those patients. The characteristics of patient admitted to the ICU, the design, sample size, outcome of all studies were highly variable. Shows the number of patients included on each country. Most ICU patients were male. And the main patient age was 56 years old. 9 studies described the diagnosis of ARDS in patients admitted to the ICU. Most patients with ARDS were male, and the median age was 35. The main outcomes regarding short-term outcome, most studies described the ICU mortality and length of hospital stay. Studies described a high ICU mortality and mortality. The mortality in patients requiring invasive mechanical ventilator was described in 6 studies. Only 2 studies described the mortality in patients with ARDS in ICU, which is 93% and 71%. Only 3 studies described the duration of mechanical ventilator, and the median time was 8.4 days. Support measures and life-sustaining therapies in the ICU. The use of mechanical ventilator was described in 23 studies, and 58% of patients admitted to ICU were ventilated. 8 studies described the use of high-flow oxygen therapy, and it was employed in 2013 patients over 9,948 patients, which is almost 20% in the ICU. 13 studies described the use of non-invasive ventilator in 25% of ICU patients. The use of ECMO was described in 18 studies, representing 2% of patients in the ICU. The use of renal replacement therapy was described in 7 studies, representing 16% of ICU patients. Finally, the use of vasopressors was described on 28% of ICU patients. So in this review, which represents the synthesis of currently available data of patients admitted to the ICU for COVID-19, with focus on the main clinical outcome, intervention used, and advanced life support measures. This review identified 32 studies and report, and it has been described as a significant number of patients who required critical care. ARDS was present in 85% who are admitted to ICU. The surge in patients with COVID-19 requiring hospitalization, ICU admissions, ventilatory support, has represented a parallel challenge to physicians, nurses, hospital managers, and healthcare systems. However, despite the rapid response of medical community, the burden of COVID-19 on ICU facilities is unclear. Despite the lack of studies, this systematic review was able to provide relevant data on ICU utilization from peer review articles, 3 non-peer-reviewed preprints, and also 5 large database of scientific institution and National Registry of Intensive Care. This review provides a unique international perspective on the interventions used and outcomes in patients with COVID-19 requiring ICU admission, thus increasing the current epidemiological knowledge and potentially providing useful information to help care of these patients. This study shows that the high burden of COVID-19 on ICU, which was demonstrated by exceedingly high mortality and length of stay, even when compared to other infectious disease requiring ICU admissions. The ICU mortality rate among patients with COVID-19 was 30%, which is relevant even when compared to the usually described mortality rate for community-acquired pneumonia, which is around 18%, and for sepsis, which is between 24 up to 55%. Moreover, when considering only mechanical ventilated patients, the mortality was exceptionally high, up to 60%, which is more than typical mortality rate from ARDS of about 45%. It is also described that the elevated ICU length of stay of COVID-19 as compared to that described for patients with severe community-acquired pneumonia, representing a challenge in the ICU bed management. This review found that almost half of the patients admitted to the ICU need invasive mechanical ventilator. In almost 60% of them, and a lower percentage of 25% requiring non-invasive ventilator. Studies in community-acquired pneumonia describe a much higher proportion of patients of about 55% utilizing non-invasive ventilation in acute respiratory failure. Indeed, the role of non-invasive ventilator of COVID-19 remains unclear. The uncertainty around the treatment of acute hypoxemia, respiratory failure with non-invasive ventilator, plus the reported risk of aerosol generation of and delayed intubation had led to varying recommendations between authorities. The use of ECMO as a salvage therapy for critically ill COVID-19 patients was limited and described in a small number of patients. Mortality in ECMO was described in only 3 studies, and it was very high, approaching 90%. It remains unclear whether ECMO therapy is associated with improved outcome. A recent study using data from extracorporeal life support organization included 1,035 patients with COVID-19 who received ECMO, and also described a high mortality about 40%, and a significant percentage of patients, 10%, discharged to long-term acute care center. Published studies from different countries describe the use of ECMO as a rescue therapy in 2009 H1N1 pandemic have been reported lower mortality rate than those reported during current COVID-19 pandemic, and this is quite significant. This review has several limitations. First, it's owing to the urgency of published preliminary information of patients with COVID-19 during current pandemic. Studies have presented very heterogeneous data on clinical characteristics, interventions used, and outcomes of ICU patients. Significant differences in design of the studies also contributed to the lack of specific and core clinical information on several reports. This is make more limitation to the ability to pool and to meta-analyze data on specific subgroups. We have would have been suggested a list of outcomes that should be assessed in future studies describing critically ill patients with COVID-19. Second, the sample size varied significantly, ranging from 20% in small cohort studies up to 6,400 patients in reports from National ICU Registry. Third, the classification of ICU patients was performed according to definition of each center. Details regarding intensive care support were not described. Hence, further stratification was not possible, and this could have led to overestimation of the surge capacity. Fourthly, that the overlap of reported cases from same centers may cause some bias. However, we believe that the large sample size and similarity of patients can minimize this effect. Fifth, that only one studies assessed the 28 days mortality, and no studies reported long-term outcome after hospital discharge. Finally, owing to several aspects, including the temporal and geographical development of pandemic, available data from the low-income countries are limited. They would be essentially the reports from Brazil and international reports that included developing and developed countries. The present review doesn't have several strengths as far as we are aware. This is the first systematic review describing the interventions used and main clinical outcome of COVID-19 patients admitted to the ICU. It describes a large number of ICU patients in 37 countries over 5 continents, and the addition of reports from a national registry, although not peer-reviewed, adds relevant and insightful epidemiological data. Our main findings reflects the substantial use of ICU beds when COVID-19 patients hospitalized. It also shows that nearly half ICU patients required mechanical ventilation and high mortality rate. So in brief, this review provides relevant data on ICU utilization of high number of patients with COVID-19 during a time of scarce resources. Patients with COVID-19 admitted to ICU have a great need for invasive support, high mortality, and prolonged length of ICU. Thank you very much. So, any question so far? Okay, I think we will have 15 minutes break till Dr. Carlos from Dr. Marcus from Ireland. He will join us for his presentation in 15 minutes. This is our last lecture. We will start tomorrow again at 2 o'clock. It's about the gastrointestinal manifestation of COVID-19 infection, virus load and fecal example from Hong Kong cohort. And this is a systematic review meta-analysis presented by Dr. Chiang. The infection of severe acute respiratory syndrome coronavirus caused the pandemic of COVID-19, which is already known. But the issue here that it is there is more than respiratory symptoms like gastrointestinal symptoms, which is leading to a shedding of the virus RNA into feces. It has been performed this systematic review and meta-analysis and published, and for the detection of virus in the stool, and also to summarize the data from cohort patients with COVID-19 in Hong Kong. Enteric manifestations of coronavirus not only pose important diagnostic challenges to the clinicians when facing patients with the mild coronavirus symptoms on initial presentation, but also signify potential fecal transmission of the disease. With the increasing number of reported cases, of COVID-19, there is a pressing need to systematically summarize the empiric manifestation of coronavirus and the temporal pattern of fecal shedding of coronavirus, particularly to the gastroenterologist and endoscopist, who may be not familiar with this disease. So this study is to summarize the existing data of gastrointestinal manifestation of coronavirus and the temporal pattern of fecal shedding of SARS-CoV-2 based on published data. The methods of this analysis, it has been found that there is 59 in one of the cohort that there is 59 patients with virologically confirmed COVID-19 diagnosed between February 2nd and the 29th in 2002 in Hong Kong. And the prevalence of gastrointestinal symptoms and viral load in the stool collected on admission was reported. The symptoms are nausea, vomiting, diarrhea, and abdominal pain or discomfort. The database which has been used for this study was PubMed, Embase, and Cochrane library, and it has been searched. Systematic review and meta-analysis PRISMA guidelines has been followed, which is between December 1st and 2019 up to March 2020. The search, the keywords that has been utilized was 2019 CON-V2 and coronavirus COVID-19 and SARS-CoV-2 or novel coronavirus. The selection criteria of two authors determined the eligibility of the studies independently, and dissonance was resolved by a third author. The inclusion criteria include study populations, patients with COVID-19, including adult, pediatrics, and pregnant. Second, the study design, case reports, case series, prospective, retrospective cohort studies, case control studies, randomized control studies. There was no language restriction. And the exclusion criteria includes patients without virological proof of COVID-19 infection, asymptomatic patients infected with coronavirus, studies that didn't report gastrointestinal symptoms, review articles and meta-analysis tutorial and from other forms. If all gastrointestinal symptoms were not reported and the number of events of any individual gastrointestinal symptoms was less than 1, this was considered not available and was excluded from the meta-analysis of all gastrointestinal symptoms. However, the study was still included in the meta-analysis of individual gastrointestinal symptoms. If the proportion of patients with that symptom was reported, 2 additional studies that didn't report on gastrointestinal symptoms but provided data on stool viral RNA was included in the meta-analysis of stool viral RNA only. The data extraction was done through eligible articles where recorded items, including first author, site of the study, including exclusion criteria, sample size, age, sex, disease severity, and gastrointestinal symptoms, and other symptoms like fever, cough, expectoration, and dyspnea. Severe disease was defined according to the American guidelines of community-acquired pneumonia, to the American Thoracic Society and Infectious Disease Society of America, Infectious Disease Society of America guidelines for community-acquired pneumonia, with the need for intensive care unit admission and death. Data analysis, which has been performed using R version 3.2.3 statistical software, continuous variables are expressed as median. The prevalence of gastrointestinal symptoms is expressed as a proportion and 95% confidence interval using the random effect model and presented as a forest plot. It has been used, the Cochrane Q test, to detect the heterogeneity among studies with p-value less than 0.1%, indicating a significant heterogeneity. It has been calculated also the statistic to measure the proportion of total variation in study estimates attributed to heterogeneity. Subgroup analysis was performed according to whether studies were from China or other countries, and in our result of this study that the disease severity patient group has been also included. Regarding coronavirus, for the result, the coronavirus disease 2019 of a cohort in Hong Kong, a total of 59 patients with confirmed COVID-19 in Hong Kong were recruited, and the median age was 58 years, with 27 men, which is almost 50%. Fever was present in 95%, and the cough was in 35%. Dyspnea in 6%, and 61% of patients didn't have respiratory symptoms or cough or dyspnea on presentation, and 25% of patients who had gastrointestinal symptoms like vomiting, diarrhea, abdominal pain, and fever didn't have a cough or dyspnea. On presentation, a stool viral RNA test results were positive in 15% of patients, and the median viral load was 4.7, and the proportion of patients with detectable stool viral RNA was higher among those with diarrhea than those without diarrhea. There was also a trend of higher stool viral load in patients with diarrhea. Of 44 patients without gastrointestinal symptoms, 10% had a positive stool viral RNA. It has been shown in the figure that the study selection process of the 2,034 studies identified, 69 of them were included in the meta-analysis. 60 studies with data on all gastrointestinal symptoms and 11 on stool viral load. The characteristics of the included studies are shown on a table, which is shown in the slides, including the hospital admission period, places in which the patients were recruited, sample size, age, sex, disease severity, and gastrointestinal symptoms on presentation, and gastrointestinal symptoms. The median age of patients was 45, and 55% were male. Among studies that reported the disease severity, severe disease accounted for 1% up to 60%. Meta-analysis of gastrointestinal symptoms. For the meta-analysis of gastrointestinal symptoms, there was a total of 4,243 patients with COVID-19. 88% of the studies were from China, and 11% were from other countries. And of the 53 studies from China, which is 50%, were from Hubei province, where the Wuhan is located. One study by Guan et al. Used the data reported to the National Health Commission from China from 552 hospitals across the country. The pooled prevalence of all gastrointestinal symptoms was 17%, with a significant heterogeneity noted among studies. For individual gastrointestinal symptoms, there were 18 studies reporting on the prevalence of lost appetite, 32 on nausea, vomiting, 58 on diarrhea, and 12 on abdominal pain. The pooled prevalence of loss of appetite was 26%. Nausea, vomiting was 10%, of diarrhea, which was 12%. And abdominal pain discomfort was almost 10%. The significant heterogeneity among studies was seen for loss of appetite, nausea, vomiting, and diarrhea, whereas the heterogeneity was less for abdominal pain and discomfort. Subgroup analysis, which is geographic variations and gastrointestinal symptoms. The pooled prevalence of all gastrointestinal symptoms were 16% and 33% in studies from China and other countries, respectively. There was no significant subgroup difference between the studies based on country origin. However, there was a significant heterogeneity among the studies conducted in China, but not among the studies from other countries. Among studies from China, the prevalence of all gastrointestinal symptoms in a single study of 1,099 patients from 552 hospitals, it was 5%. And for studies from Hubei province, and the pooled prevalence of all gastrointestinal symptoms was 16%. Whereas for those from outside Hubei province, it was 18%. There was a significant subgroup difference between the studies from and outside Hubei province, and there was also significant heterogeneity among the studies. Disease severity and gastrointestinal symptoms, there was 11 studies that compared the prevalence of all gastrointestinal symptoms according to the severity of COVID-19. And the pooled prevalence of all gastrointestinal symptoms was 17% in patients with severe and non-severe disease respectively. There was a significant heterogeneity among the studies. Adult pediatrics patients and pregnant women, there were 53 studies on adults, 4 on pediatric age, and 3 on pregnant women. The corresponding pool prevalence of all gastrointestinal symptoms in adults, pediatric, and pregnant were 16%, 24%, and 20%. So you can see that the pediatric have a higher tendency to have symptoms for gastrointestinal symptoms because of coronavirus. Detection of viral RNA in the stool. None of the studies tested stool viral RNA on the day of hospitalization, except our current study. There were 12 studies that tested for viral RNA in the stool. The study by Wang et al. Reported the stool viral RNA positivity rate according to the number of stool specimen rather than the number of patients, but reported the stool viral RNA resulted among 13 patients who tested positive for respiratory specimens. Of 138 patients, 68 tested positive for both respiratory and stool specimen, which is almost 48%. That was after hospitalization. And 9 studies with serial viral RNA test results of patients with around 87 of 124 patients, and a persistent positive stool viral RNA despite negative respiratory symptoms. Ling et al. Reported that the stool viral clearance was longer in patients with steroid use compared to those without steroid use. Results in 38 patients with available details. Based on the available data, none of the studies reported patients presenting with diarrhea on presentation. Presence of viral RNA in stool was longer than respiratory specimen. In 13, including 7 pediatrics patients, viral RNA was detected as early as 3rd day of illness onset in these patients, and remained positive for more than 33 days in some patients. So what do we have here, and how do we explain this? That in this meta-analysis of 4,243 patients with COVID-19 from 6 countries, the pooled prevalence of all gastrointestinal symptoms was 17%. Loss of appetite was the most common gastrointestinal symptoms, almost 25%, followed by diarrhea, 12%, nausea and vomiting, 10%, and abdominal pain discomfort, almost 10%. In the Hong Kong cohort, viral RNA was detected in the stool of 15% of patients on presentation, including patients without any gastrointestinal symptoms. Moreover, patients with diarrhea on presentation had higher stool RNA positivity and viral load than those without diarrhea. We also noted that almost 50% of patients had a detectable stool viral RNA during the course of illness. More importantly, prolonged shedding of viral RNA in the stool rather than respiratory samples was observed in 70% of patients, which could be up to 33 days from illness onset. Although diarrhea is one of the common gastrointestinal manifestations, the presence of constipation could not rule out COVID-19, as case report of 4 patients reported that constipation was noted. Despite the inclusion of more than 60 reports, the actual prevalence of any gastrointestinal symptoms could be underestimated because many earlier studies did not report other gastrointestinal symptoms except for diarrhea. Moreover, the majority of studies reported gastrointestinal symptoms only on the day of admission, but not throughout the disease course. The issue is further complicated by the difference in the criteria for diagnosing diarrhea in various hospitals. With more than 80% resembling coronavirus infection of gastrointestinal tract is not unexpected and is proposed mediated via angiotensin converting enzyme 2 cell receptors, and which is highly expressed in the small intestine, especially in proximal and distal enteroside. And in the binding affinity of angiotensin converting enzyme 2 receptors determine the infectivity because it modulates intestinal inflammation, and the coronavirus may cause disruption of those receptors and result in diarrhea. A recent study showed intracellular staining of viral nucleocapsid protein and angiotensin converting enzyme 2 protein expression in the human gastric, duodenal, rectal epithelial cells, further suggesting that the receptors could act as the entry point of SARS infection in the intestinal tract. Gastrointestinal manifestations were also commonly reported during SARS and MERS outbreak. In the previous SARS outbreak in Hong Kong, 16% of patients reported diarrhea. Similarly, up to the quarter of patients with MERS also reported gastrointestinal symptoms such as diarrhea or abdominal pain. In our COVID-19 cohort in Hong Kong, 22% of patients reported diarrhea, which was slightly higher than our previous SARS cohort. However, many of these patients contracted the virus in a large outbreak during a dinner gathering in some of Lunar New York, New Year, probably via both fecal, oral, and respiratory routes. Thus, partially explaining the higher frequency of gastrointestinal manifestation. Previous studies during SARS showed that viral load in the stool was strongly associated with the presence of diarrhea. And our COVID-19 cohort, particularly with diarrhea, also had a higher prevalence of detectable stool viral RNA on presentation. The most important gastrointestinal manifestation may be the only initial symptoms in some patients with COVID-19. In one study by ANITAD, 9 patients reported only gastrointestinal symptoms in the absence of fever or respiratory symptoms on presentation. Subgroup analysis showed that the pooled prevalence of gastrointestinal symptoms was lower in studies from China than other countries, although any true difference between countries remains to be investigated. This observation could be due to the smaller number of patients in studies from outside China. Also, it is noteworthy that many of these early reports from outside of China included visitors from China. Because China was the first country affected by COVID-19 outbreak, with a large number of patients, the gastrointestinal manifestation may have been overlooked in the beginning of the outbreak, particularly Wuhan City, leading to under-reporting of the gastrointestinal symptoms in earlier studies. This meta-analysis showed that the prevalence of severe disease was more common in patients who had gastrointestinal symptoms than those who didn't. Wang et al. Reported that abdominal pain was more frequent in patients who required ICU care than those who didn't. Healthcare professionals should be aware of the potential prognostic implication in patients with gastrointestinal symptoms who may require closer monitoring. In this cohort study in Hong Kong, it has been found that 15% of patients tested for positive for stool viral RNA on the day of admission. As for meta-analysis, it has been found that almost 50% of patients has had stool samples ever tested positive for viral RNA during the illness. Because of the lack of systematic stool collection protocol in currently published studies, the full extent of the stool positivity rate remains to be characterized, particularly the peak timing and extent of fecal shedding. It is, however, alarming not to note that 70% of patients had stool viral RNA remaining positive despite negative respiratory specimens, although it is uncertain at this moment whether these are live virus particles or just RNA fragments released from intestinal cells. This finding could raise serious concern about isolation policy for patients with COVID-19, particularly during recovery phase. During SARS outbreak in 2003, it was reported that the sewage system in some places in Hong Kong served as a major source of infection from patients exerting coronavirus RNA. The sewage concentrates of 2 hospitals receiving patients with SARS and Beijing were also found to have coronavirus RNA detected in that time. So the proper handling of excretions of patients with COVID-19 should still be strongly enforced, despite repeatedly negative results in respiratory specimens. Another interesting feature of COVID-19 is the recurrent infection in some patients, that is, recurrent symptoms after apparent recovery with positive respiratory symptoms for viral RNA, again after initial clearance. It remains to be determined whether the persistence of viral RNA in stool may be used as a surrogate monitor for recurrent infection in some patients. There are several strengths of our studies that, to our knowledge, this is the first meta-analysis to summarize the rapidly emerging and sometimes confusing literature on COVID-19 on the prevalence of the overall and individual gastrointestinal manifestation. The comprehensive inclusion of more than 60 studies allowed a more precise estimation of the prevalence of gastrointestinal symptoms. Subgroup analysis found that the presence of gastrointestinal symptoms was associated with a more severe disease course, highlighting the importance of more detailed inquiry into the gastrointestinal symptoms for both diagnostic and prognostic purposes. The alarming high prevalence of viral shedding in the stool, particularly after viral RNA negativity and respiratory specimen, prompt further research into the viral shedding dynamics in different systems, and as well as the potential transmission risk via the fecal-oral route, which carries a significant infection control and public health implications. A few limitations of this study should be noted. As mentioned, gastrointestinal symptoms may be underreported in some studies and may lead to a lower pooled prevalence rate. Second, studies with larger sample size ethnic group other than Chinese are currently lacking, precluding a more precise estimate of the prevalence of gastrointestinal manifestation in ethnic groups. So in conclusion, it has been found in this study that the gastrointestinal symptoms were present in 17% of patients diagnosed with COVID-19. Moreover, viral shedding in the stool was detected in almost 50% of patients and could persist up to 33 days from illness onset, even after viral RNA negativity and respiratory specimen. Thank you very much. Any questions, please? Okay, thank you very much. We will meet tomorrow, inshallah, at 2 p.m. after Jum'ah prayer, inshallah. And I think you have the timetable already. Thank you very much.
Thank you, Dr. Muhammad. And
so we'll meet tomorrow at 2 p.m. Dr. Ahmed.
إن شاء الله الساعة 2 بإذن الله.
Okay, thank you very much.
Thank you. شكرا للجميع. Thank you for all audience and all speakers, and we will meet tomorrow إن شاء الله after 2 p.m. Thank you for all.
Thank you.
Thank you.